So good evening everyone. If I am visible and audible, please give me a thumbs up, guys. So good evening everyone. I can't see the messages. Just let me go through it once. Okay. Yes, so anyone can give me a thumbs up, guys. I can see myself, but just waiting for a response from anyone who's around. Yes, anyone around? So anyone, just give me a thumbs up, guys. Good evening everyone. Alright, so anyways, let me just start with the session, guys. So this is a previous year's question PYQ session on INICET that we are doing, and here we'll be discussing all the important questions which have been there. And this series that we have started is more for you to get accustomed or acquainted with the kind of questions that are being asked. Alright, so we'll not waste a lot of time, and let me just start with the anesthesia part of it. I am your anesthesia educator, Dr. Vinish Sir, and I'm going to discuss the anesthesia INICET PYQs, right? All the previous year's questions which have been there. I get a good evening from Dr. Sara. Dr. Sara, good evening. So let me start with the session, and if I can get messages from you guys, I'll be happy about it, so that we'll have a kind of a discussion session. And for me, I think that is one thing which I always look forward to, responses from all of you. Let me start straight away with the first question, and here is the first one. These are all PYQs that we are discussing, right? So give me your answer, A, B, C, D. Dr. Swati says good evening. Good evening everyone. Good evening. So I'll be discussing you why INICET questions are different from NEET PG. I'll be discussing that also. The first example is this, the glaring example of it. Which of the following is true regarding benzodiazepines and barbiturates? I'm going one by one, the different papers which have been asked. I'm starting right from your May 2025. I'll be going to November 2024, May 2024. Then we'll go to November 2023, May 2023. One by one we'll be going down and trying to see the questions from anesthesia and realize how they are different from the NEET PG and FMG questions which are there. So anyone, what's the answer for this question? Remember, these INICET questions are slightly tougher. Most of the times anesthesia questions are easy, but the recent trend that we are seeing is that you need to have a good idea about the subject, only then you'll be able to answer this. So anyone? Dr. Sara, Dr. Swati? Dr. Javed says A. Very nice, Dr. Javed. Very good, very good. Okay, so Dr. Javed has said A for this question. Let us see what is the question, how is the answer that we get. Which of the following is true regarding benzodiazepines, right? So they are asking a question regarding benzodiazepine and barbiturates. Both of you must have studied benzodiazepines anyways. You have studied in pharmac as well. Okay, so both of them act on GABA A receptors. Yes, both of them are causing CNS depression. Both these drugs are going to cause a CNS depression. Dr. Swati also says yes. A. Correct. Dr. Swati, you are also right. Absolutely. Okay, so both of them are going to cause CNS depression, even barbiturates as well as benzodiazepines. By what? By working on the GABA receptors. So this statement is a true statement. Alcohol causes supra-added CNS depression. Is it true? Because when you take alcohol, does the CNS get depressed? Yes. Alcohol also works on the same GABA receptors, right? Alcohol also works on the same GABA receptors. It produces CNS depression, right? Therefore, this is also a true statement. Now, looking at the third one, flumazenil, all of you know, you must have studied that in benzodiazepine. So, does it reverse the action of both? No. Remember, flumazenil, all of us know it as a benzodiazepine antagonist. Okay, this is a benzodiazepine antagonist. It reverses the effect of benzodiazepine. So remember, benzodiazepines are normally very safe drugs. But a question that comes from benzodiazepine, if there is a side effect that you're worried about regarding benzodiazepine, I'll be worried about two things. No, more than two things, just one thing. and that is respiratory depression, which happens in two places. Normally, respiratory depression with benzodiazepines would take place if you take a high dose. You must have seen that in, when people take high doses of sleeping pills, they land up with respiratory depression, right? There is so many deaths which have been reported with that as well. Why? Because respiratory depression is one of the side effects that can take place when you give a high dose of benzodiazepines. And second thing is, respiratory depression takes place especially in anesthesia if we have given a benzodiazepine combined with opioids. A combined dose leads to respiratory depression, and if I want to reverse the respiratory depression, this is the biggest side effect that I'm worried about. If I want to reverse this, here I'll be using flumazenil, and that flumazenil cannot be used with barbiturates. Why? Barbiturates is your drugs like phenobarbital, right, which you have studied in pharmac. You have studied this in medicine. From anesthesia point of view, drugs like thiopentone, that is a barbiturate. Also another drug called methohexitone or methohexitol, that is a barbiturate, and these drugs cannot be reversed by flumazenil. The last point is regarding thiopentone itself, which is anesthesia drug, right? So thiopentone has short duration of action due to rapid metabolism? No, not because of that. A short duration of action is not due to rapid metabolism. The half part of the statement is correct. So does it have a short duration of action? Yes. This part of the statement is correct. I want you to pay attention to this thing, That is how INICET questions come. Do you see one statement? The statement has two parts to it. One is regarding the short duration of action, and the other is the reason for this short duration of action. And this is what the point I wanted you to pay attention to, that short duration of action, yes, it's a true statement, but rapid metabolism is not true. This statement is false, right? But short duration of action is due to redistribution, guys. It is not because of rapid metabolism. So now the point is, half part of the question is correct, but the remaining half is wrong, and the one before this is false. So therefore we land up with 2 points. Point number 3 and 4, both of them are false. So therefore the correct answer, as mentioned correctly by Dr. Javed and Dr. Swati, is option A. Clear? That was the first point. So I just wanted you to pay attention to the kind of questions which have been asked. This is May 25 INICET. Okay, next question. If there are any doubts, you can ask me in between, guys. If there are any doubts, I'll try to solve them. But the whole aim of this session is for you to be aware about the type of questions which come and not taking a lot of time. I'll try to finish off as early as I can. Okay. Now, next question. I would love if you can give me answers immediately. Right? A patient underwent cardiac surgery with vecuronium as muscle relaxant. After the surgery got completed, which of the following agents is used for reversal of this drug? Okay. Recently, they've been asking questions about the reversal agents and neuromuscular relaxants. This question comes from there. All right. So here it has been mentioned. Dr. Javed has given one answer. Dr. Javed, your first answer was very correct. Second में थोड़ा सा point है. फिर से read करो. Try to change it if you can. Dr. Javed. All right. Now is the point. You read the question correctly. That is where we make mistakes. This is where we make mistakes. You guys are well read. You have studied well. But in trying to mark the question fast, you just mark the answer. Right, Dr. Javed. It must have been a printing error. A typing error. But the point is do not do the same thing in the exam. Simple question. Don't lose marks here. So Dr. Javed, Dr. Tirumalesh and Dr. Swati, absolutely correct. Simple question. The previous one was difficult, not this one. Patient has been given vecuronium. Vecuronium is a muscle relaxant. All of you are aware of that, right? When you are giving a muscle relaxant, the muscles get paralyzed, right? The whole point about this was to cause paralysis. When you speak of vecuronium, remember this is a non-depolarizing muscle relaxant. Always remember, when you speak of, I'm adding this point onto it, that when you speak of muscle relaxants, right? I'm just adding into it because I wanted a session where your revision also gets done. So muscle relaxants can be divided into two types. One are the depolarizing muscle relaxant. The others are the non-depolarizing muscle relaxant. There's only one depolarizing, which is succinylcholine. Rest all, whatever you study, whether it is pancuronium, whether it is vecuronium, whether it is rocuronium, whether it is atracurium, all of these drugs are non-depolarizing, right? Remember, simple point, non-depolarizing means these drugs have no depolarization, and that is exactly why they lead to paralysis. But the problem with depolarizing drugs is that they cause depolarization. There is depolarization taking place, and depolarization means some muscle movement. Therefore, these are associated with fasciculations, and that is why non-depolarizing, they have no fasciculations, because there is no depolarization. But after fasciculations is when the paralysis takes place. So after the fasciculations is when the muscles get paralyzed, right? Flaccid paralysis. Now, the point is, depolarizing agents are working as their succinylcholine. It sounds like acetylcholine. So these drugs are basically non-competitive in nature. Because they are non-competitive in nature to what? To acetylcholine. They work like acetylcholine. So they work as an agonist at the receptor. On the other hand, non-depolarizing drugs, vecuronium, rocuronium, pancuronium, these are competitive drugs at the receptor. Competitive to what? Competitive to acetylcholine. So because they are competing with acetylcholine, their effect is not like acetylcholine. So these drugs become antagonist at the receptor, right? They are opposite to acetylcholine and they will compete with acetylcholine, right? So therefore, when you give drug like succinylcholine, you are causing depolarization, fasciculations, paralysis, and later on you don't have to give anything, because this succinylcholine gets destroyed by plasma cholinesterase and you will need no reversal. Correct? On the other hand, here paralysis took place because of competitive block, because depolarization did not take place, right? The drug was sitting on the receptor. But here what will happen is, in case you want to reverse the effect, you want to finish the effect, this is not going to affect over here. It's not going to work like this immediately. What you need to do, here you will have to give a reversal. Because it's a competitive block, I will give neostigmine to the patient. So once I give neostigmine, neostigmine blocks the enzyme acetylcholinesterase. It leads to increase in acetylcholine. Because of being competitive block, it pulls the acetylcholine more inside the receptor now, and vecuronium is thrown away. This is what is called as reversal. So remember, reversal is the neostigmine. You must have heard that we also give atropine or glycopyrrolate with that. Why? Because the increase of acetylcholine does not take place only at the nicotinic receptors, it also takes place at the muscarinic receptors, and at the muscarinic receptors it's going to lead to muscarinic side effects. So neostigmine, guys, is combined with glycopyrrolate or atropine. This was NEET PG question. Okay, with glycopyrrolate or atropine to take care of the muscarinic side effects, not the reversal. So the reversal drug is not glycopyrrolate, it is not atropine that just takes care of the muscarinic side effects. It is neostigmine, which is the reversal agent. That is the answer. Clear? So whether they give you atropine, whether they give you glycopyrrolate, there was a question asked in NEET PG that these are the drugs which cannot reverse muscle weakness. Thumbs up, guys. Did you understand? I've tried to discuss the complete mechanism in as short time as possible. Hopefully you've understood. Cannot reverse the muscle paralysis. Okay, I know you're all aware of that, but I just wanted to discuss all the points regarding muscle relaxant in just this much. Hopefully you've understood this. Okay, thumbs up, guys. Okay, so that's a clear revision. Hopefully we'll go like this only now. Every question will take some points and discuss the important aspects of it, so that your revision also gets done. Acha, two things are left. What about baclofen? That's a muscle relaxant which takes place. You must have taken, you know, when we give baclofen, now this is not peripherally acting at the peripheral muscle, so it goes from there. So it's out from the anesthesia point of view. So baclofen is not important from anesthesia, and dantrolene is important. Yes, this is also important drug. This is important in anesthesia for what? Again, questions come based on dantrolene. This becomes your antidote or maybe treatment for malignant hyperthermia. Why? Because dantrolene stops the release of calcium. That's the property of dantrolene. It stops the release of calcium. That is the mechanism. So therefore, remember, malignant hyperthermia was what? Malignant hyperthermia is a disorder of sarcoplasmic reticulum, ryanodine receptor gene abnormality, and this ryanodine receptor is nothing but a calcium release channel. So malignant hyperthermia is a disorder of the calcium release channel, right? Where calcium gets released and it leads to all the problems, you know, malignant temperature increasing, arrhythmias, myoglobinuria, muscle rigidity, all that takes place. And the only treatment is to stop this calcium release by giving dantrolene. All you do is you stop the calcium release, and that's how it works. That's the treatment. Dr. Synergism says RYR over here. Correct. All of you are correct, guys. So this point is also done. So we've discussed malignant hyperthermia also. That's an important question. Recently they've been asking questions on that also. Clear? So hopefully this point is clear to you. Next one. Again, last, this is May's questions. All of you, if anyone has seen the paper, you must have seen this question also. All right. Few, of course, see, these are all recall questions that we have. Recall means what the students have recalled from the exam. And many times you don't get the exact names, exact points, and you know, everyone is from here and say only. So we cannot always say that, yeah, this was the only question, because they have not given us the question exactly how it has been framed. From all the here and say, all the platforms, I'm not talking of only this, all the platforms always do the same thing. From here and say of the students is how things are done. So this was one question that came regarding lumbar puncture, and all of us expect that it is a question from medicine. But how the questions get asked, now you look at it. Which of the following statements is true about lumbar puncture? The first thing now they have said is lumbar puncture is urgently indicated if the CT is negative in a suspected subarachnoid hemorrhage. Can you see the twist? It's not about anesthesia. It's not about direct medicine. Am I right? That's how questions come. Now, so urgently indicated if CT is negative in suspected subarachnoid hemorrhage, right? This is the first point over here. Post-dural puncture headache is common in females and older age. So you have to again divide, as I said, urgently indicated, is it true or not? Yes. This is a true statement. You know, you will have to see it. You will have to get a CT done. I mean, if the CT is negative, LP has to be done. So this is a true statement. Post-dural puncture headache, coming to anesthesia now. Post-dural puncture headache is common in females. Yes, this part is true. Absolutely true. But it is common in females. It is seen in young patients and who are pregnant in nature, not in the older age group. This becomes a false statement. Meningitis after LP is an unusual side effect. Unusual. Does it happen every time? No, it is unusual. So the first statement you got true. Meningitis after lumbar puncture is unusual. That is true. Right? So you have got two options where 1 and 3 are correct, but 2 is false. So you can easily rule out option number A and option number 2. Right? Option number C. These two options are out. So your answer is left between B and D. Right? Still we'll confirm it. B and D are two things. So even if you don't know, right, just from these three statements you've got your answer. You have to see something where you get 1 and 3 correct, and that is seen in the option number D. But let's see the fourth statement. The fourth statement says that lumbar puncture is done in safely done, safely, in thrombocytopenia less than 10,000. No. Normally, if you will say, see, spinal anesthesia, when we speak about spinal anesthesia, we, practically speaking, some books have mentioned 1 lakh, but remember, practically speaking, we take up to 70 to 80,000. Less than that, we do not do spinal anesthesia, right? A patient having, in fact, that is a contraindication. You know this, a platelet count of 70, 80, coagulopathy. Remember, a coagulopathy is a contraindication for, absolute contraindication for spinal anesthesia. It's absolute contraindication. So therefore, here they have said less than 10,000. All of you know, in dengue patient, someone gets a platelet count of 10,000. Forget anesthesia. Dengue, what do? You start giving blood transfusion. So do you want to do a lumbar puncture in a patient whose count is less than 10,000? Is it safe? No, it's not safe. So therefore, it is not safe. This becomes a false statement, and therefore the answer 1 and 3 are correct, and therefore option number D, correctly said by Dr. Javed, Dr. Synergism, Dr. Swati. Okay? Absolutely. All of you have said it correctly. The answer is D. Is it right, guys? Clear? So the point of discussion, as I said, was to understand that is how questions are getting asked in the exam. Don't look at one statement always. There are hidden points given in the INICET exam. They are making statements, divide them into two. All of you play dumb charades. INICET play dumb charades. Play dumb charades by cutting the sentence in between and trying to see if the first part or the second part is correct or not. NEET PG FMG questions many times are simple. So for example, this question came very simple. Here you don't have to cut so much. The options were single tracks. But when you get statements like this, guys, cut the statements like dumb charades. Cut them into two parts. Look at one part, look at the second part, and see if both of them are correct or not. Based on then derive on your answer. Hopefully this point is clear. Next one. As I said, let's go to the last year's question now. This was last year's November question. Ambu Aura 40. right? They had asked AMBU for 40 is first generation, second generation, third generation, fourth generation LMA. As I said, these are all PYQs of INICET. We have not included the NEET PG PYQs. No, all of them are available on the net. Everything is there. Even we have taken a session recently. So we are not discussing that. We are discussing the INICET questions, AMBU or 40. Now, ideally, they should not be asking names like this because AMBU is the name of the company, right? So, but anyways, they've asked before also, what is AMBU full form? Artificial Manual Breathing Unit, all that has been asked. So, AMBU or 40. Now, the point is, all of us think that AMBU or 40 was going to be a second generation, but no, it is not. Remember, out of all the AMBU LMAs, and of course, as a undergraduate student, you're not supposed to know this, but still, because it has been asked in exam, out of all the AMBU LMAs, ideally, the only one which is second generation is AMBU Aura Gain. Right? This is a first generation LMA. It's not a second generation. Okay, AMBU Aura 40. What happens is, the importance about AMBU Aura 40 is that it can be recycled. Not recycled, but reused. It can be reused like a normal classic LMA. So AMBU Aura 40 is like a classic LMA. So what is a classic LMA now? So guys, remember when we discuss laryngeal mask airway, so we normally classify laryngeal mask airway into two types. We classify them into first generation and second. So remember, fourth generation does not exist. But guys, nowadays a third generation has also come. Okay, third generation is a new thing. You just have to, you don't have to know it, but just to add on to your information, extra information, there's something called as a Baska tube. As I said, you're not supposed to know this, but just to tell you that, you know, there is something called as third generation also, which exists nowadays. They call it the third, not officially printed, but a lot of people say this Baska tube is a third generation LMA. So LMAs are basically first and second generation. At your level right now, let's just stick on to the fact that LMAs can be of two types, first generation and second generation. The difference is that the first generation is going to have only one airway or ventilating tube. This has only one tube, which is one airway tube or the ventilating tube. But the advantage of second generation is that this is the first generation, this is the second generation. Second generation not only has this one airway tube, but apart from that, all of you would be aware it has got one drain tube also. The advantage of the drain tube is that from the drain tube, I can insert a nasogastric or a Ryle's tube in stomach, and by inserting that in the stomach, I can do a suctioning from there, right? So now if I do a suctioning from there, in that case, what happens is this helps you to, yes, Dr. Synergism says another tube for aspiration. Yeah. So this putting that extra Ryle's tube or nasogastric tube in the stomach helps me to suction the stomach. So if the stomach contents are full, this helps me. Remember, the word is that it does not prevent aspiration. It helps you to decrease the chances of aspiration. This is the word, huh? It does not prevent aspiration. It decreases the chance of aspiration. Therefore, we get an advantage that in anesthesia, I can use it for positive pressure ventilation. And this cannot be used for positive pressure ventilation because there are high chances of aspiration. So this was low chances of aspiration. Here you get high chances of aspiration. And this cannot be used for IPPV or should not be used. So this has, first generation has high chances of aspiration, right? And under anesthesia only for a spontaneously breathing patient. In emergency I can use it for anyone, huh? But under anesthesia only for a spontaneously breathing patient. Now what are the examples? So first generation LMA, the examples are going to be the classic LMA, the intubating LMA. I am coming to fast track. Dr. Javed, just give me a second. I am coming to that. Intubating LMA, guys. Intubating LMA is also, I was coming to that point, Dr. Javed. Intubating LMA is called as fast track LMA. Okay. Then the third is flexible LMA, which has that wire inside. And the fourth one is unique LMA. This is a single use LMA. Right? These are your first generation with one tubes. The second generation are the Pro Seal LMA. The supreme LMA, which is used in difficult airway, it has the anatomical shape. You have I-gel. Remember, I-gel is a cuff-less LMA. There is no cuff. And the fourth one is what I just discussed, AMBU aura gain. So they become these four that you need to remember. AMBU aura gain, not AMBU aura 40. These are our first and second generation. Dr. Javed, okay, clear? Fast track LMA is an intubating LMA. So that is your first generation. Clear everyone? Thumbs up. So I'll go to the next question. Hopefully everyone okay with that. Right? So Dr. Javed's answer also done. Dr. Synergism said I-gel, another tube for aspiration. Correct. So both the points are correct with all of you. I think your revision is done with this part at least. Okay. This part has done. Next question. Simple one. Now again, here you don't need to play drum charades in the exam. Questions like these are easy. Don't waste time. Just give your answer and run to the next one. These are the questions which help you save the time. Which drug shows adrenal gland suppression? Succinylcholine, propofol, etomidate, ketamine. All of you have studied anesthesia well. You're preparing well for INICET. I don't even need to discuss. Easy question, etomidate. Okay, etomidate. Remember, etomidate when you're speaking about, right? Etomidate, that is the biggest side effect that it has. So if you have to speak about side effects of etomidate, right? The side effects of etomidate, if you have to speak about, remember the most important here is adrenal suppression. This is the most important. Rest all are there, I'm not denying, but adrenal suppression, which decreases the cortisol synthesis, this is the most important. Apart from that, myoclonus and hiccups are important. Nausea, vomiting is very important, right? And it can cause focal seizures, right? That is myoclonus itself. So you can remember it as focal seizures. And the last point is it's highly painful in nature. Okay, so these are 4-5 points which can take, which are the problems with etomidate. Okay, so adrenal suppression, myoclonus, nausea, vomiting, focal seizures, and painful injection. Okay, there you see there are different ways you can remember all the points out. For everything you can make one mnemonic, but just remember these points over here: that adrenal gland, myoclonus, nausea, vomiting, focal seizures, and painful. So a simple way, once again. Doctor, one second. Dr. Thirumalesh is asking me, one second, my screen is not seen here. It's got fixed onto this. Wait. Alright, just give me a second. Alright, visible everyone? So Dr. Thirumalesh is asking me, sir, most painful etomidate or propofol? Okay, most painful etomidate or propofol. So if you ask me, okay, and why is the reason, I'll tell you. Propofol always most painful, right? According to me. Why? When you speak of etomidate, guys, nowadays etomidate comes in two forms. So since we're discussing etomidate, let's discuss other points about etomidate. That etomidate comes in two forms. One is that it comes as a milky white emulsion, and remember, emulsions are always painful. It comes as a milky white emulsion, right? And as I said, emulsions are always painful because it's an emulsion. But apart from that, etomidate also comes nowadays as a transparent liquid. Now this is not very painful, guys. So in that case, the reason is that there are two forms of etomidate available. But when you speak of propofol, always remember propofol is the one which is absolute. Just like etomidate, it is only a milky white emulsion. Milky white emulsion. Now, emulsions always contain some oil. That's why it is, it is called emulsion. So etomidate contains something called propylene glycol. On the other hand, propofol's contents, it's asked in the exam, and whenever we teach that also. What are the contents, anyone? Remember, there are 3 contents of propofol. 3 contents, propofol. What are these? Anyone? Do you remember egg? Yes, apart from egg, anyone? Egg, lecithin. Very nice, Dr. Synergism gave that answer first. Egg, lecithin, glycerol and soybean oil. These are the contents of propofol, and that is exactly why it's a good culture medium, because it contains egg, it contains glycerol, it contains soybean oil. It becomes a good culture medium which can grow Pseudomonas and E. coli. I think you all studied that. Nosocomial infections, and that is the reason you need to discard the vial within 6 hours. Throw it away within 6 hours. That's the point. A used vial should be thrown away. And that's the reason why this becomes a very, very painful injection. So propofol is a highly painful injection. So if someone will say in terms of grading, remember most painful is propofol, which is almost the same as etomidate, but it is available in transparent form also. So that's not very, very painful. So propofol almost the same, but either of the two, if you have to choose, the answer is propofol. Whenever you give propofol, that's the reason correctly said by Dr. You add lignocaine, Dr. Synergism. You always need to mix with IV lignocaine to decrease the pain. Right? And coming back to that point, with propofol, etomidate, the next one that is most painful after that is methoxytone. Remember that barbiturate with thiopentone? So that methoxytone followed by thiopentone, and the last is ketamine. Remember, ketamine drug is actually analgesic. These are painful ones. All these we said are painful. And here I want you to bring a point. Remember, all the painful drugs are the ones which are working on the GABA receptor. Remember, we just discussed GABA. Ketamine is the drug which works on the NMDA receptor. This drug works on NMDA receptor, and it is an analgesic drug. Because ketamine is directly opposite to all of them. You must have seen the properties of ketamine also, not like others. Ketamine properties are different from all of them. So ketamine is analgesic. It works on NMDA receptor. Rest, all these anesthesia drugs, the induction agents are working on GABA receptors, including the inhalationals also, right? Even the inhalationals work on the GABA receptors. So methoxytone, thiopentone, etomidate, propofol, inhalationals, midazolam, all these drugs work on GABA receptor, and ketamine works on NMDA receptor. One more point, you must have studied anesthesia, right? All of you have prepared well. You must have also been knowing that drugs like nitrous oxide and Entonox also have analgesic property. Remember, Entonox is used for labor analgesia and dental. Remember, these drugs also work on NMDA receptor. So drugs working on the NMDA receptor, they have analgesic property. So nitrous oxide and Entonox also work on NMDA receptor apart from ketamine, and they are also analgesic. Thumbs up, guys. Okay. Clear? So we discussed propofol, etomidate, ketamine, the important points. So propofol, the most important side effect that you get is a painful injection. And apart from that, especially in pediatric patients, it can cause propofol infusion syndrome, which is failure of free fatty acid metabolism. Okay, which leads to lactic acidosis. So propofol infusion syndrome, especially in pediatric patient, that is a problem, and painful injection. And of course, if you're using as an infusion, it's going to increase all the oils in the patient, triglyceride and lipids, everything will get increased, right? Speaking of ketamine, we have discussed only good properties, analgesia, NMDA receptor, and I said it's opposite to all of them. So ketamine, remember, it has another property, right? Ketamine, no doubt it's working on NMDA. It produces something called as dissociative anesthesia, which is different from any other type of anesthesia, right? It works on NMDA receptor, analgesic and dissociative anesthesia. This is one drug which can produce, when the patient is coming out of anesthesia, this one produces emergence delirium, which means hallucinations, dreaming. So someone feels very good after taking ketamine, बहुत मजा आता है. You enjoy ketamine. No, you don't enjoy ketamine. Whoever takes ketamine, they enjoy ketamine. I hope you understood what I said. Okay. Whoever takes ketamine enjoys ketamine. Right? Who's given ketamine in the hospital? Normally pediatric patients, and they love it. Okay. That's exactly why you get a CT scan and MRI done. Right? The kids are happy in their own world. Once you give them ketamine, they are happily sleeping. Otherwise, all of you who are interns and post-interns, you would be knowing that when you take a pediatric patient for MRI, have you seen the baby sleep? The baby never sleeps. You give midazolam, the baby sleeps. You put the baby in MRI, the baby gets up. Am I right? Okay, so ketamine, it produces dissociative anesthesia. It is very commonly used for out of OT procedures, and it is also used as an antidepressant. Last year's question, right? Another question which has been asked. So it produces dissociative anesthesia. It can be used for out of OT anesthesia. It is also used as an antidepressant. I think all of you are aware. Recent question. Remember, psychotropic drug used in used to treat psychotropic new and psychotropic drug used for psychosis, no, and to treat depression. The answer was ketamine. This was asked in NEET PG or FMG. I don't remember. Okay, but this is a recent question now. So dissociative anesthesia, it produces emergence delirium, it produces hallucinations and dreaming, and secretions. It increases secretions. And that is why you need to add glycopyrrolate when you give ketamine. Hopefully this point is also done. So we've discussed etomidate. Succinylcholine I discussed with you before also. Depolarizing muscle relaxant. And we've discussed propofol, etomidate and ketamine as well. Okay. Any questions and doubts you can ask me guys in between. Okay. A patient after RTA presents with fracture of 3rd to 8th ribs and is not having sufficient pain relief with systematic analgesic. Okay. What would be the next best course of management to reduce the pain? Is it supraclavicular brachial plexus block, cervical plexus block, lumbar epidural block, or a thoracic epidural block? Yes. So who will give that answer? Anyone? RTA. A patient had road traffic accident. Alright, and this patient, correct. So option, Dr. Swati says option D. Correct, Dr. Swati. Correctly. Thoracic epidural block. Supraclavicular brachial plexus block is here. Okay. Correct. Supraclavicular brachial. Just think anatomy knowledge, na? Anatomy. Don't even think of anesthesia. Think of anatomy. You have a patient who is presented with fracture of 3rd to 8th rib. So 3rd to 8th rib is thorax, na? Forget simple anatomy. Let's go back to first prof. Supraclavicular means above the clavicle. And where is the fracture? Which region? The fracture is in thoracic region. So if you give someone something in the supraclavicular area above the clavicle, how is it going to take place of the thoracic region? Out. Cervical plexus block. Cervical. You know, cervical vertebra somewhere there. Even if it's correct or wrong, we don't know. But let's think about anatomy point of view. No, it won't work. Lumbar area is L1, L2, L3, L4. Okay. If you have to take care of a thoracic pain relief at T3, imagine how much drug you'll have to give. What is the better answer? Thoracic. It corresponds to the thoracic level. Simple. Okay. The answer is D. Alright. Thoracic epidural block. That is what is being done. So remember, this is a new treatment for flail chest. Not new, but initially what the treatment was for flail chest was, they mean fracture of the ribs. So patient has difficulty in breathing. If you have exercised, you know, if you do a pull up, chin up, you know, all of us sometime when we do like this, suddenly a muscle gets pulled. If you have pulled, and then you know what happens when you try to breathe, neither the air goes in, nor you can leave your air out. And that happens with a small muscle injury. If you injure your muscle, if someone's rib is fractured, how will they breathe? The breathing goes away. It's very difficult to breathe, and that is why you have to give analgesics so that they can breathe well. And remember, most of the time initially these patients used to be put on ventilator, IPPV and ventilator. This was the treatment, right, apart from analgesics. But then with the use of epidural, the number of patients that you need to put on ventilator has decreased. You have to monitor them closely, take care of their pain, and then they get better even without putting them on ventilator. Right, that was the point. So here the answer is thoracic epidural block, and hopefully this is clear. Alright, next. Okay, let me ask you one thing. One question that comes about supraclavicular that I want you to remember for the exam point of view is that this is the most common used of the brachial plexus block. Out of all of them, this is the most common used. It is the one which causes the complication pneumothorax. Most commonly, the pneumothorax complication is seen with supraclavicular. Pneumothorax complication is seen with supraclavicular. Right? This is one thing that I need you to remember. This has been asked in the exam. It has come as a clinical question. You know, someone was been given a block and then suddenly pneumothorax took place. So what is your, which of the following is correct? Here the answer was supraclavicular brachial plexus block. right? Next question. Which of the following, so all of you must have seen this last year's paper, right? Which of the following is true about resuscitation in a child? So we're discussing a pediatric patient's resuscitation. The chest compression should be 1/3 the antero-posterior diameter of the chest. The compression to ventilation ratio is how much? It is 30:2 with 2 rescuers, right? Adenosine is the preferred drug given by intraosseous route, and adrenaline is used as 0.01 mg per kg, 1:1000 dilution. So I have all the students giving me the answers. Dr. Synergism says A, Dr. Ritika says B. What is the answer? As I said, now when you get a statements like this, cut them. You need to play dumb charades now. Okay? Start playing dumb charades. What is the dumb charade? Chest compression should be 1/3. Okay, chest compression correct. You have to do it. It should be 1/3 the anteroposterior. हाँ, ये तो है ही यार. You got the true statement here only. But let's see the other question now then. You got the true statement in the first option itself. So don't think that if the first option has been given, it is wrong. Don't think that. So always think, yes, you have to read, have your knowledge. Chest compression 1/3 the anteroposterior depth. Correct. This is a true statement. Your answer is here only. You got the answer. Compression to ventilation ratio is 30:2 with 2 rescuers. Compression. In an adult, it is correct. But here you are speaking of pediatric patient with 2 rescuers. Here it is not 30:2. It becomes 15:2. Correct? Adenosine is a preferred drug given by intraosseous route. First of all, this patient is undergoing resuscitation. Resuscitation means CPR. Chalo, CPR can be divided into 2 parts. You can talk about 2 things. One is basic life support, advanced life support. When you speak of BLS and ALS, remember there are only 4 drugs which are used. In advanced life support, in fact I made a Instagram post also recently. A lot of students have seen that. You can follow me on my Insta also. My Insta is dr.vinish. I'll put it in the end also. dr.vinish. Okay. So I discussed that. I made that mnemonic, not simple mnemonic. You can also make it. But the 4 drugs which are used in ALS, right? 4 drugs. Books have normally mentioned 3, right? So they have mentioned as epinephrine or adrenaline. Epinephrine or adrenaline. The second drug that is used is amiodarone. The third that has been mentioned is lignocaine, right? Normally these 3 are mentioned even in the ACLS guidelines. A 4th one is also there, guys, and that is magnesium. Magnesium is used for torsades pointis, right? So therefore you can remember these 4 drugs. That's the Insta reel I made, and that Insta reel is MEAL. The 4 drugs that are used in CPR are MEAL. M for magnesium, E for epinephrine, A for amiodarone, and L for lignocaine. These are the 4 drugs you can remember. So therefore adenosine is not one of the drugs that is used for resuscitation in the CPR per se, right? So therefore given by intraosseous route, yes, if you had to give ADR, that is fine. If it was given, ADR is given by the intraosseous, yes, it is correct. Intraosseous route is used, no doubt. Always the guideline have said IV or IO, intravenous or intraosseous, so that is correct. But adenosine is not used so much. It is adrenaline for resuscitation. I'm not talking of patient who is like unstable or stable. Here you are doing a resuscitation. 4 drugs: epinephrine, amiodarone, lignocaine, magnesium. That's it. Okay. Last point is ADR is used. Of course it is used. Is ADR used? Yes. In 0.01, yes. Even this is correct. But 1:1000 dilution for resuscitation? No. 1:1000 dilution is used for anaphylaxis. This is given through the IM route. ADR, questions that come in exam. 1:10,000. This is what is used in CPR. When you speak of CPR, it is given IV or intraosseous as mentioned before, but it is not 1:1000. We use 1:10,000. That is right. Apart from that, you can also use for normal infiltration, local anesthesia. For infiltration, local anesthesia are used anywhere between 1:80,000 to 1:2 lakh. And that's why you get that ampule of lignocaine and ADR, which is 1:2 lakh. Alright. Of course, one more point is there that you can use ADR through the nasal route nebulization in bronchial asthma. Bronchial asthma, you can use nebulization with adrenaline. So these are the uses of ADR, and this is a general question that comes in the exam. Okay. So for a bronchial asthma patient, Nebulization. So this is used from which route then? It goes from the nebulization. Clear everyone? Dr. Synergism says not mg. नहीं 0.01 है ना, वो भी correct है, but if you give 0.01, so you're saying a microgram, हाँ तो ठीक है, mcg हो गया, that will going to be mcg, right? It will go like this. Clear? Okay, Dr. Synergism. Clear? Simple question next. So this was one difficult one which came in between. All right, and then we come to the next one, Jackson-Rees circuit. Now this was again last year's question, and questions on breathing circuits were not asked for the last how many years, you know? 1, 2, 3, 4. Almost for 4-5 years they did not ask a question of breathing circuits. A lot of students said, sir, let's not study. Just because they are not asking recent questions on anesthesia machine, they have not asked questions recently so many on cylinders. Just because they have not asked, you know, before this circuit, they have not asked. Remember, it does not mean you're not supposed to study them. This is a basic of anesthesia. Questions on anesthesia machine and cylinders can be asked anytime. Okay. So here, remember that point. Okay. Dr. Tirumalesh and Dr. Ritika and Dr. Synergism have given absolutely correct answer. That is pediatric anesthesia. Correct. Okay. So remember, when we speak of breathing circuits, now just describe them in short. Okay. I hope you see, for me I have no time constraints, and hope you also don't have time constraints. You okay now, all of you? The way we are considering the session, the way we are continuing it. Let's do it the same way. Breathing circuits can be classified into 3 types. Okay, breathing circuits are basically classified into 3 types. At your level, the first, of course, for our level also is open circuit. There's semi-open and semi-closed. When we study in post-graduation, we study them as semi-open and semi-closed, but undergrad level, remember that it can be semi-open or semi-closed. We'll take both of them together. Simple, it's just one thing, and then you can remember closed. At your level, both are the same. Open circuits are not used now. These were the old methods by using that mask. By using just a mask, you know, Schimmelbusch mask and all, we were using that. This was done for ether and chloroform, not used now. The semi-open or semi-circuits, open circuits that you know are these Mapleson circuits. The closed circuit is what we call as a circle system. Now, the point is, Mapleson circuits are made from A to F by the arrangements of fresh gas flow, by the arrangement of the bag, by the arrangement of the tube, by the arrangement of the valve, the expiratory valve, and the mask. These arrangement of the 5 things make the Mapleson circuits. Based on that, A to F is there. Dr. Tirumalesh says, sir, please take the time. Done. Thank you. Okay. Because I was thinking just to rush off, but I think all of you, the kind of responses I got, all of you were keen, you were answering well. So let us discuss it so that your revision only gets done. I don't mind that. Okay. So thank you for that, Dr. Tirumalesh. If you find it's getting little, you know, we are going out of the board. See, my point is that every question, let's discuss the points related to that also. It helps you to revise it, right? There's no harm revising when you're preparing for the exam. The number of revisions are important. Remember, so now we discussed Mapleson. I told you Mapleson have 5 things: a fresh gas flow, bag, tube, valve, and the mask. Circle system is what contains soda lime, right? Now the point is, presence of soda lime helps you for one thing. It helps to absorb carbon dioxide. Because carbon dioxide is absorbed, so what happens? Whatever came out of the patient, see, this is expiratory valve. What came out of the patient came into the atmosphere. What came out of the patient? Nitrous oxide. What went inside was oxygen, nitrous, inhalational. What came out was carbon dioxide, nitrous, inhalational. What I did was, I absorbed this carbon dioxide which came out of the patient, and after absorption of carbon dioxide, I put the same thing again inside the patient. I am reusing. Remember, in childhood we used to study reuse, reduce, recycle. I am doing the same thing. I am reusing, reducing, recycling, and this helps me to decrease the amount of anesthesia drugs given. It is preventing environmental pollution, and that's why circle system is a great method for giving anesthesia. You absorb carbon dioxide and you reuse anesthesia gases by removal of carbon dioxide, and therefore you are rebreathing. The patient is rebreathing his gases, but carbon dioxide is removed, right? But in these two, there is no rebreathing. patient does not rebreathe and it goes out, because here you are reusing this as rebreathing. Clear? Okay. So circle system also has been asked recently. They have not asked it, but remember, circle system is what contains soda lime, right? And soda lime can help you absorb carbon dioxide where you are reusing anesthesia gases. It is used for anesthesia. It's a very good method to use it for anesthesia. But out of them, the old methods presently are not used for anesthesia, but this is used and this is used for anesthesia. Use in anesthesia. Mapleson circuits, I said A to F. Even before I go to A to F, remember first thing is Mapleson A, B, C, D, E and F. In Hindi there is a word called BC. Nothing more. So we will not use it. Okay, let's not use the word. It's not nice. Let's not use it. So therefore it has become obsolete. B and C not used. It's obsolete. What is used? A, D, E and F. Right. So out of that also, remember, dumb charades. We'll divide into two parts. Okay. So therefore, now what happens is, here are the two types of patients we get, adults and pediatric. So what we can do is, this goes for pediatric, right? And this is going for all the older people who are there. Means it's going for adults. So children go for E to F, and here adults are going between A and D. All right. Now, so this is the first point. Out of that also, the E1 is rarely used. It is rarely used. Rare. That is what is called Ayer's TPs, and it is rarely used. For peds also, this is not used. So we are left with only one, that is F. So remember, in exam they are going to ask you basically 3 circuits only. At your level now only 3 circuits become important: A, D and F. So remember, F is what gets used in a pediatric patient, right? E was used for neonates, but we don't use it so often. It's not the most common used. And remember, the A and D are used for adults, right? So if someone has to be given IPPV, so in this case we will use Mapleson D. If someone is breathing on his own, right, older patient breathing on his own, which means spontaneous breathing, we will use Mapleson A. So Mapleson A used for a spontaneously breathing adult, Mapleson D used for IPPV in adults, Mapleson F used for pediatric patients, and this is your answer. Remember, B, C and E normally they will not ask you. Okay, is that okay? So now coming to this point, pediatric anesthesia. So Jackson-Rees is nothing but Mapleson F. So you need to know the names also. So Mapleson A, there are 2 names to it, that is McGill circuit and Lack circuit. Mapleson D is the most common used, which is called as Bain circuit. Okay, and last is Mapleson F, which is called as Jackson-Rees circuit. Jackson REE. Remember, J and R is junior, and that is pediatric. Clear? Clear everyone? Okay. So therefore, neuro, cardiac, obstetric, everywhere if you want to use, you can use for the circuits that are used for adults or pediatric depending on that. But this was pediatric anesthesia. I'll be using Mapleson F. Okay. So here the answer is Mapleson A. Mapleson answer is option A, which is the pediatric anesthesia, Jackson-Rees. Hopefully clear everyone. We've had that revision also done. Next. Again, this is last year November only, I think. This is again, we are still sticking to 2023 November question. Which of the following is an incorrect statement about thiopentone? Again, dumb charades. Start playing dumb charades. Okay. Here you get the answer based on dumb charade. The rapid decline in its effect is due to renal excretion. You have to identify, we are supposed to identify the incorrect statement, not the correct statement, which means there is one false and 3 statements which are correct. Okay. Anyone? Rapid decline in its effect. Is it true? Is there a rapid decline in the effect of a drug? Yes. That's why what we first give induction of anesthesia when you put someone to sleep, and apart from that you need to give maintenance of anesthesia. Right? Why you need to give maintenance? Because there is a rapid decline in the effect. That's why you need to give maintenance of anesthesia. Right? Is it due to renal excretion? Which means if you give thiopentone to someone, right? I've given thiopentone. The effect takes place between 10 to 15 seconds, which is 1 arm brain circulation time. Right? It goes to the brain. It stays in the brain for about 10 to 15 minutes. Right? And then it is out of the brain, because of which the decline gets over. I mean, there's a decline in the effect, anesthesia is over. So is this 10 to 15 minutes, is it cause excretion? 15 minutes the drug has got excreted? No. Rapid decline is yes. Okay? Rapid decline is yes. Is it due to renal excretion? No. Is it due to renal excretion? No. That's not the reason. Right? Does it have a high lipid solubility? Yes. That's exactly why it goes inside the brain. Lipid soluble structure. Right? It has a high lipid solubility. Yes. It is given as fast IV injection. हाँ, fast दो slow दो यार IV जाएगा. चलो ठीक है. Correct. This is yes. It rapidly increases the brain concentration. Yes. That's what we wanted. Can you see all yes, yes, and yes. Is it redistributed to adipose tissue and muscle? Yes. And that answer was given by Dr. Synergism. Yes. And that is the reason for rapid decline. Alright. So therefore, the rapid decline is there, but it is not because of the renal excretion. The rapid decline in the effect is because of redistribution from the brain to other tissues. That's the reason for the short duration of action which you see, because the drug from the brain now moves out into the adipose tissue and the muscle, and because of that effect in the brain decreases. Therefore, the correct answer, which is incorrect over here, what statement is incorrect, is option A. Clear everyone? Okay, see, that's how you have to tackle these questions, and remember, these questions are time consuming. Okay, a question like Mapleson circuit is not time consuming. This you have to answer in 5 seconds and move to the next question, because this year you have to play dumb charades. In these questions you have to break the points, you have to see each of the other options. Remember, these are the questions which take time. So you cannot consume 1 minute in a question like this, Jackson-Ree circuit, and then you think, oh, I'm going to complete. This is when we are unable to complete the paper. So many times you know the answers, but you're unable to. So you know that time management becomes important, for which we say that GTs are important. GTs are not important. Of course, they're important to see your score also, but GTs help you in learning effective time management. Okay, so please give GTs. So option A is the correct answer. Next. Okay, another one. And as you can see, these are not the normal questions which are coming in, you know what we study. Can you see this? All the kind of questions which are coming from INICET. These are not your NEET PG common questions. That's what comes in INICET, and that is how it becomes different from a NEET PG exam. Which of the following must be avoided in post-cardiac arrest resuscitation care? In fact, after INICET, a question like this came in FMG also based on the same concept. Not so much in detail, but based on that. So this is what we are discussing, not a cardiac arrest now. CPR done. CPR is done. They are asking after the CPR, the patient is got revived. After the CPR, patient is got revived. Now what is not to be done? Okay, patient has got revived now. So after you did CPR, you did a good CPR, you saved the patient's life. What will you not do? If a patient has been saved and you have shifted the patient, so they are talking of patient who's unconscious and post cardiac arrest, the patient has been shifted to the ICU. Okay, so if the patient has gone into the ICU, post cardiac arrest, mostly in the ICU, the patient must be on ventilator, or the patient must have been intubated, right? Intubated, tracheostomy, whatever have been done on ventilator. Mean arterial pressure over 65. Yes, you need to maintain that here. Why will you want to avoid? You have to maintain the BP because he is saved. You have to maintain the SpO2 because he is saved. While you are doing CPR or he has collapsed, do you know the reason behind it? No. So therefore you do an ECG. We do that in everyone. In the ECG you have seen there is ST elevation. You were doing the CPR, there must have been a block, right? And ST elevation is seen. So will you do a cardiac cath lab? Yes, you will shift the patient to cardiac cath lab. If need be, you will revascularize, right? Bring down the body temperature to below 32. Below 32 is hypothermia. So ideally you will not do that. So this is clearly explained. You will not going to bring it less than 32. So this is the incorrect statement. It is to be avoided. But there's a point. Remember, bring down the body temperature is correct. Dumb charades. But the point is not below 32. Not below 32. This statement is divided into two parts. Bring down the body temperature. Yes, it is called therapeutic hypothermia, which you have studied in pediatrics. Therapeutic hypothermia. You must have heard about it. Yes or no? Below 32 is not correct. It has to be maintained between 32 to 36. That is therapeutic hypothermia. Thumbs up everyone. Clear? Alright, so this is how questions come in the exam. Not that we have not studied, it's how we are using at that point of time in the exam, how we are thinking about it. Okay, so here below 32 is not the right answer. Had it been 32 to 36, it was correct, guys. So this basically is a part of the adult out of hospital or in hospital cardiac arrest. You must have seen there are 6 circles. OD has 4 circles. So in CPR there are 6 circles, 3, 4, 5 and 6, which basically says out of OT cardiac arrest, out of hospital cardiac arrest and in hospital cardiac arrest. Dr. Synergism says excellent session. Thank you Dr. Synergism. मेरा बस चलता तो स्क्रीनशॉट निकाल लूँ मैं इसका, but anyways let us finish off the portion because all of you are giving time over here. Okay, thank you so much Dr. Synergism for your comment. Anyways, we were discussing the adult link of survival. So this is called as adult chain, or it can also be called as link of survival. Right, so it starts from 1, 2 and 3, 4. So this is the first chain, second link, this is the third link, this is the fourth link, this is the fifth link, this is the sixth link. Ideally you should study 1, 2, 3, 4 both, all. But remember, this can be divided into 2 parts: in hospital cardiac arrest and out of hospital cardiac arrest. Now, why to study so much? Remember, 1, 2 and 3, 4 are different for in hospital and different for out of hospital. But the one which is common between the two is 5th and 6th. So they will ask you questions basically about the 5th and the 6th. Okay, so the 5th point is post cardiac arrest. Okay, resuscitation care. It is called post cardiac arrest care. Post cardiac arrest care. This is the question on which they have asked you. And the 6th link is recovery, and based on this question was asked in the FMGE exam, and they had asked what is the 6th link in the adult chain of survival, and so many students who did not study did not know where this question has come from. Okay, the 6th, these small points is where they ask you. So this question was asked in INICET, the same question which is based here, and based on that they asked you this question in FMGE: what is the 6th link in the adult chain of survival? Okay, so therefore the 6th link is recovery and the 5th link is post cardiac arrest care, where you are maintaining the blood pressure, you are maintaining the saturation, you maintain the respiratory rate, intubation, cardiac cath lab. One more point is there, you need to do neurological assessment. A neurological assessment is also an important part. Okay, therapeutic hypothermia is important, and cardiac cath lab. These 5-6 points are important that you need to know. Rest, first, second and third, fourth, even if you don't study, it's okay. It contains of high quality CPR. So one point over here is high quality CPR, early defibrillation, shifting to the patient to the hospital as early as possible, which you are already aware. 1, 2, 3, 4, let's leave out, but 5th and 6th are common to both of them, and this is where they will ask you the questions. First, second, third, fourth, they won't ask you. Okay, next. Okay. Again, this question is a part of surgery, it's a part of gynae, it's a part of anesthesia. But I included it because this question was asked, and nowadays they are even practically speaking, this question has become very important nowadays, because when you are practically working in the hospital, you will find a lot of gynae, lot of surgeons saying, what is the ERAS protocol? What is the ERAS protocol? So this is called Enhanced Recovery After Surgery Protocol. It contains 5-6 points which are there, which you must have studied in surgery. I'm not going to go into details of everything. It is like a patient comes to you for surgery. What are the things that you are important in preoperative? What are the things important intraoperative? And what are the things important postoperative for a patient to have early recovery? Okay. These are 3-4 points. Basically, it is centered around this point that a patient has to recover early. How you as a doctor are going to help the patient, you must be aware of this part. You must have studied this. So there are preoperative points, intraoperative points, and postoperative points. The point is the patient has to recover early. What has been given to us? Avoid prolonged preoperative fasting. Right? They've asked which is true. Which is true means one statement is going to be true and rest 3 are going to be false. False fluid. So avoidance of prolonged pre-operative fasting. Fasting guidelines nowadays, questions have been asked 2, 4, 6, 8. Remember, you can take fluids for up to 2 hours before the surgery. So do you want a patient to be fasting for 8 hours normally? No. Clear fluids only 2 hours. So therefore, Avoidance of pre-operative fasting, this is a true statement. Fluid should be given leisurely. Keep on giving fluids leisurely, as much as you want. As much as you want. Are you supposed to do that? No, you have to be taking care. You just can't be giving it, the way that you want. This is not a correct statement. Next, we will see, especially post-operative. This is important, post-operative part. Okay, this was the pre-operative part here, right? Fluid should be given. You have to restrict the fluid. You're not supposed to give a lot of them. You can't give leisurely. So remember, that is intra or post-op. You have to restrict the fluids. Okay, they are not giving leisurely. Remember, it is restricted. Restrict. Okay. Post-operatively, good pain control with opioids. All of us think, yes, why not? Patient should have a good pain relief, no doubt about it. But remember, opioids have their own side effects. Opioids, they can cause sedation, they cause constipation, right? You're aware, they also cause urinary retention. All these questions are asked in the exam. They cause respiratory depression, am I right? These are the clinically bothersome side effects of opioids, whether you give fentanyl or you give morphine. So respiratory depression, urinary retention, sedation, right, constipation, all these are part of it. Now, patient has good control, yes, very good. But if you want an early recovery, opioids becomes an hindrance to it. And that is why when you see the pain management chart, the first thing they start is always with the paracetamol or, the basic drug, PCN. They say once you take care with PCN, the next part is you can add NSAIDs to it. Diclofenac. All of you must have practiced it during internship. You give paracetamol to a patient, you add diclofenac. They say along with that you can add COX-2 inhibitors. After that the patient does not get a good pain relief, then they say with that you can now add opioids, okay, which are not very potent. That's why you must have used drugs like pentazocine, Fortwin. You must have used that in the wards. So they are not very, very strong opioids. These are moderate, okay, not very strong opioids, less strong opioids. Or agonist antagonist. Only if it does not get controlled with this is where you go for strong opioids like morphine or fentanyl. This is what is called as multimodal analgesia, and routinely for a daycare surgery, patient has early recovery, this is what we need to follow. So this is a statement. So therefore, do you want good pain relief with opioid? I want a good pain relief, but I'll be trying to use a multimodal analgesia, right? Different drug and combinations, and I will try to avoid opioids. Till the time I can avoid, I will avoid opioids if I want an early recovery from the surgery. And second thing is, post-operative feeding should be delayed. No, again this is not said. They say you should start it as early as possible. Okay, should be delayed? No, as early as possible. As early as possible. So nowadays they even say within 2 hours we give some fluid, and some people in pediatric patients, they start giving little bit of water even within 1 hour. Okay, so these are those new points, these are those points clinically which are relevant, which have been asked. So this question regarding enhanced recovery after surgery, ERAS protocol, is important. Okay guys, so remember it's about pre-op, intra-op and post-operative things which are needed, and here the correct answer is A, which most of you have already mentioned. Okay, ERAS protocol is an important question. Next, do you realize it does not even seem like an anesthesia class? That's how questions come in the exam. It doesn't even seem that they've been asked from anesthesia. The INICET paper, do you realize? Such simple questions they are not asking. This was asked, but such simple questions they are not asking. They don't want you to answer simple questions. Okay, so give me the answer to this one. Correct. Dr. Shashank says CO. Dr. Thirumalesh says CO. Very good. Very nice. CO fluorine. Absolutely correct. Okay. Inhalational agent used in children. Alright. So if you have to just discuss the inhalational agents which are used for what? So I'll just discuss 2 points about each of them. Remember, when you say isoflurane, normally isoflurane contraindications, side effects are very less apart from one. That being a coronary vasodilator, it can cause rarely something called as a coronary steal phenomena. That is one of the side effects you see. It is slightly pungent and slight bronchial irritant. Therefore used only for maintenance. So this is not used for induction. Right? Sevoflurane, when you speak of side effects, if I have to think about side effects of sevoflurane, right? So these are the side effects or wrong points about each of the drug. Sevoflurane side effect that I can normally think of is just one thing, that if you use it with soda lime at fresh gas flow less than 2 liters, theoretically it can lead to formation of compound A, which is nephrotoxic. This is the only place where you don't use sevoflurane. Apart from that, you can use sevoflurane anywhere, right? This is the only place where sevoflurane is not used in a kidney patient. Desflurane then becomes a drug of choice in a kidney patient. Okay, but apart from that, desflurane has few points which are important. First thing, it is maximum pungent out of all the agents. Maximum pungent means it is also maximum bronchial irritant. Not to be used in pediatric patients, not to be used for inhalation induction, right? Apart from that, it can produce delirium post-operatively, right? Post-operative. This is known. Apart from producing delirium, it also leads to some amount of sympathetic stimulation, because of which it can be useful also in a patient of shock, but slight increase in heart rate and BP. It also causes environmental pollution. Right. So these are 4-5 points which are not very good about desflurane. So you find sevoflurane is the only drug which has the least amount of complications compared to all of them. Sevoflurane is also fast acting. It is useful in children. Okay. Now, speaking about nitrous oxide, if anyone will say what are the side effects or problems with nitrous oxide, basically there are 5 or 6. It is teratogenic in nature. You can't use it in pregnant ladies. It causes lot of nausea, vomiting. These are simple points. It causes vitamin B12 deficiency. All of you know megaloblastic anemia and all that 4 points from there. Then it is also causing environmental pollution. Again, MCQ question, right? It is combustible in nature, right? It is not used in laser surgery. And apart from that, it expands closed air spaces, means anything that contains air, right? It expands closed air spaces. So any space in the body which contains air becomes a contraindication, like not to be used for GI surgery, not to be used for anything in the lungs, not to be used for neurosurgery, high chance of embolism, not to be used in eye and ear surgery. These are becoming contraindications. So that's about nitrous oxide, the side effects. So I discussed nitrous, iso, sevo, des. Last point, let's discuss important points about halothane, because this has got the maximum complications, maximum side effects. All right. So halothane is a good drug, nice sweet smelling drug, but the problem with halothane is hepatitis. The problem with halothane is arrhythmias. The problem is malignant hyperthermia, right? And it's also a good uterine muscle relaxant, so we can use it for manual removal of placenta, but the side effect is it can cause a postpartum hemorrhage. All right. So hepatitis, malignant hyperthermia, arrhythmias, and shivering, another side effect. So these are the points with halothane which are the side effects of halothane. Clear, guys? So if anyone will say which drug is to be used in which place, right? So if you get a patient who's CVS, I will prefer to use isoflurane over sevoflurane and desflurane. I get a patient with a kidney disorder, renal disorder. I get a patient who is obese, right? I get a patient who is in shock. In these conditions, I will prefer to use desflurane. Kidney patient, obese patient, and shock, I will use desflurane. Daycare surgery, now there's a division. People say desflurane as well as sevoflurane. Both can be used. Okay, they're almost the same. Then we discuss about the CNS. In a patient of CNS, let's start with liver first. In a patient of liver, which is a non-hepatotoxic drug, is sevoflurane, but you can use iso and des, both. Liver patient. When you speak about what is that? CNS. In CNS, again, sevo is better compared to iso and des. Both can be used. Last we have to discuss is about the respiratory patient, bronchial asthma, and pediatric patients. In these patients, sevoflurane is preferred over halothane. So according to me, this is where the most of the answers will be. You will have confusion in two places. A lot of books have mentioned for CNS, the choice is isoflurane. It's not wrong. Why? Because isoflurane is important because it maintains the intracranial pressure. Sevoflurane is important because cerebral blood flow, least increase. So if the answer is related to intracranial pressure, the answer would become isoflurane. So that's why both answers are not wrong. But ideally speaking, nowadays sevoflurane is preferred over isoflurane for CNS. In CVS, remember, isoflurane is the most is the most cardiostable drug. It maintains cardiac output. So it is always preferred over sevoflurane, though sevoflurane can be used. So you'll get one problem here also. Some books have mentioned for CVS, sevoflurane drug of choice. Some have mentioned DES, but ideally it is ISO, according to me. Others are not wrong, but that's the best answer according to me. Clear? Next question. Alright, so here I discussed according to me what is the best points. So it doesn't mean other people are wrong. That is the best knowledge that I can gain from whatever I know. Alright, I'm sharing my knowledge. That's it. Which of the following is not a component of a high quality CPR in adults? Simple question now, right? But still you have to read them properly. Depth of chest compression up to 3 to 4. Allow adequate chest recoil. The ratio of chest compression to ventilation is 30:2 and chest compression rate is 100 to 120. Okay. So the depth of chest compression, you have to see which one is not a component of high quality CPR, right? High quality CPR is one of the points of this. Remember I discussed with you this chain. In this chain, one of the points is high quality CPR, right? High quality CPR, what are the points when you're giving a chest compression? So that's the answer that we need to find out. Correct? So Dr. Synergism says A. Correct. Absolutely correct. Okay? So depth of chest compression means when you give a chest compression, how much should be the depth? It's not 3 to 4. It should be 5 to 6 centimeters. Allow a chest recoil? Yes. Ratio is correct? Yes. Because they mentioned adults. Had it been pediatric, it would depend with one rescuer or two rescuers. We just discussed that point out. But otherwise for adult, it is 30:2 and rate is 100 to 120. Yes. Okay. Dr. Synergism says 5 centimeter. 5 to 6 hai, correct hai. So you have, there are 2 points given in the books. 5 to 6 centimeter and 2 to 2.4 inches. Okay. These are the 2 points given regarding the depth, and this for adult as well as pediatrics, this is supposed to be 1/3 the depth of the anterior-posterior diameter. Remember that we saw before. This is 1/3 the depth of the chest. 1/3 the depth of the chest. Okay. Okay. So this question is simple, easy. Answer was A. When you get questions like this, you feel so good, na? Otherwise, these were taxing questions where you are playing dumb charades. These were taxing questions. The same thing happens in exam. You are sitting already for an hour and a half. You realize when such questions come, it eats your brain, right? When these questions come, it feels easy. Yes, you know something, right? Same thing happens in exam. So that is why we say keep on giving GT. Don't miss out GT. It prepares you for the exam. Alright, simple question now. A patient was planned for surgery. अरे ये तो मैं discuss कर चुका. नहीं discuss नहीं किया. A patient was planned for surgery under GA. In the induction phase, rocuronium was given to the patient, but there was unsuccessful intubation. Which of the following drugs can be given for immediate reversal effect of the drug? Yes. Which is the drug? Immediate reversal. Till now, reversal drug we had seen was neostigmine. Correct? Neostigmine. But once you give neostigmine cannot be given immediately. Okay? If you want to get immediate reversal of a drug, means here what has happened, if you see the scenario, the patient was given GA, the patient was given rocuronium with a muscle relaxant, and you were not able to intubate, means patient is gone. You have to take the drug out as early as possible. You can't be giving neostigmine. You want an immediate reversal of the drug, and yes, for that the correct answer is Sugama Dex, right? This is a cyclodextrin which is used. This causes a very fast and immediate reversal. It's like a chelating agent or a binding agent. It binds to rocuronium and pulls it away. So it's not playing with that acetylcholine. Remember when we gave neostigmine, neostigmine was blocking acetylcholine esterase and therefore increasing acetylcholine. This was the problem, and this was increasing in the nicotinic receptor as well as the muscarinic receptor. Okay, that was the reason why we gave atropine, because of the increase in the muscarinic receptor, the side effects of muscarinic receptor, right? So anyways, neostigmine and atropine are combined for that reason as a reversal. They are combined as a reversal, but you can't give it for immediate reversal. For fast and immediate reversal, Sugama Dex works like a binding agent. It binds and takes it away. Okay, so it's working more like a binding agent, right? Sort of that. Sugama Dex. Remember, Sugama Dex was specifically made for rocuronium, and they've also said it can be used for vecuronium as well as pancuronium, but most important it is for rocuronium. Hydrophonium, yes, this can also be used here. This is also anticholinesterase, but normally if you want to use it, remember this is a short acting drug. So therefore this can be used only for 𝐒𝐴𝐷, the shortest acting muscle relaxant. This is the shortest acting non-depolarizing muscle relaxant. So of course for that you might not need to give a reversal, because 𝐒𝐴𝐷 gets metabolized by plasma cholinesterase. What is plasma cholinesterase? Remember? Plasma cholinesterase, do you remember? If you don't remember, let me remind you. Plasma cholinesterase. Remember succinylcholine? It gets destroyed by plasma cholinesterase and no reversal needed. Same thing with 𝐒𝐴𝐷. If it gets destroyed by plasma cholinesterase, why will you need a reversal? But in case if you want, is where you can use hydrophonium. Clear? This was succinylcholine. Same thing. So 𝐒𝐴𝐷 has a property that it gets destroyed by plasma cholinesterase. Sorry, I'm doing up and down, but that was the point, just to go back and discuss succinylcholine with you. So it has short duration of action. Here you can use hydrophonium for 𝐒𝐴𝐷, but otherwise 𝐒𝐴𝐷 does not need a reversal, because 𝐒𝐴𝐷 by itself gets metabolized by plasma cholinesterase. That is why it is said to be the shortest acting non-depolarizing muscle relaxant. Clear? Non-depolarizing, otherwise shortest out of all of them is succinylcholine. Clear? Next question. Okay, this we discussed before, but anyone answer? Which of the following is a second generation LMA? I think you should be knowing now. Yes guys, sorry. Which of the following is a second generation LMA? Pro-seal LMA, intubating LMA, flexible LMA, or AMBU LMA? Let me see the answers. Yes, anyone? One second. So answers given are, almost of you are saying correctly. Yes, A. Pro-seal LMA, second generation, correct. Pro-seal, we've discussed that now. Any doubt on pro-seal? No, na? All of you are okay with that? So I think everyone is given. Dr. Shashank says A and D. Nahi, AMBU ka, correct. Here's the confusion. Intubating, this has got two tubes. Airway tube and drain tube. Intubating LMA is the same fast track which you were asking me before. This and flexible have only one tube. AMBU LMAs normally are one tube. Normally, AMBU LMAs, this question had come before AMBU or a game question that came in the exam. Most of the AMBU LMAs are first generation. The only one that I know is except AMBU or a gain. And AMBU or a gain is the only one which we know as a second generation that we have mentioned before. Apart from that, most of them that I know from AMBU are basically first generation. Only AMBU or a gain is a second generation. Okay, so this is the point about AMBU, and I think that point is clear. किसी ने डॉक्टर शशांक ने पूछा था क्वेश्चन ना, ठीक है, क्लियर हो गया. नेक्स्ट. ओके, अगेन, which of the following is not a method for free flow oxygen delivery to a newborn? So this again is a question. Now we have come to which year, पता है? This is 2023 now. Before this was 2024. I think this question is where 2023 starts. Yes guys. Which of the following is not a method? Remember the question is which one of the following is not a method for free flow oxygen delivery to a newborn? Yes. First point, an oxygen tube kept close to baby's nose and mouth, oxygen mask placed firmly over the baby's mouth and nose, self-inflated bag attached to the mask placed on the baby's nose and mouth, and a reservoir bag attached to the ऑक्सीजन मास्क प्लेस्ड केप्ट ओवर द बेबीज माउथ एंड नोज. ठीक है, कंफ्यूजिंग ना? एनीवन? यस गाइस. Which of the following is not a method for free flow oxygen delivery to a newborn? Oxygen tube kept close to baby's nose and mouth. Oxygen mask placed firmly over baby's mouth and nose. Self-inflated bag attached to a mask placed over the baby's nose and mouth. Reservoir bag attached to oxygen mask. Do you understand what this question has been asked? What are they asking? These are oxygen delivery devices. This question is discussing oxygen delivery devices, right? Which one is not a method for free flow of oxygen? What is the meaning of free flow? Means you just keep a mask and you go away. Means you are there in the ward, you get a patient, you just need to attach the mask or something that gives oxygen. You're just supposed to see that. That is a question asked. A patient is in the ward or anywhere. You just have to give a mask and you're supposed to give oxygen. That is a question asked. The oxygen tube, you keep an oxygen tube close to the baby's nose or mouth. Will it give oxygen in the ward? Can you do that? Yes. If a baby is lying in the ward, you just keep a tube, oxygen tube. Will it give oxygen to the baby? Yes. But better than that is you keep a mask. Instead of just keeping oxygen tube, you hold a mask on the face, like you keep a normal simple face mask. This is a simple face mask. So what is the meaning of this? The one before. It just means the one before is talking about the plain oxygen tubing. This is plain oxygen tubing which you attach to a mask. It means a plain oxygen tubing which you attach to the end of a mask. It is that. So can you keep it on the baby? Yes. I can keep it on the baby and baby will get oxygen. But if I keep a mask, it's much better. That's a simple face mask. Self-inflated bag. Self-inflated bag attached to a mask placed on baby's nose and mouth. Self-inflated bag. This is talking about AMBU. All of you must have done. It's sort of AMBU. Okay, unless and until you give positive pressure, this is going to give IPPV. The baby is not going to get oxygen. You keep an AMBU bag on someone's mouth and go away. All of you have worked as interns and post-interns. If you just keep an AMBU on someone's mouth and you walk away from there, remember the patient is in the ward, you just have to give mask. You have an AMBU bag also, na? The AMBU bag contains a mask. In front of the AMBU bag there's a mask. So you take the mask, put it on the face and you go out. Can you do that? No. If there's an AMBU bag, you are supposed to give the positive pressure to the patient. You have to give the breath to the patient. That is called self-inflated bag, right? And this cannot be given as a free flow. The last one that you can see, a reservoir bag attached to oxygen mask. What is this? Non-rebreathing mask. Can you give that to a baby? Yes. What is the answer? C. Thumbs up. Is it clear, everyone? Thumbs up, guys. Is it clear? Very. All okay, everyone? Because I'm not getting your messages. Refresh karu. Let me refresh. I can see myself, but I can't see the messages. Now I can see the messages. I was, this option has been given by Dr. Synergism and Dr. Shashank, but I was not getting the messages. Correct, guys? Correct. Okay? Absolutely correct. When we discuss oxygen delivery devices, remember, again, important question in the exam, oxygen delivery devices can be classified into two types. Oxygen delivery devices can be classified into two types. One is low flow, other is high flow. The low flow devices are what we already know: nasal cannula or nasal prongs, the simple face mask, right? Partial rebreathing mask, non-rebreathing mask. The maximum oxygen by nasal cannula is around 45%. Maximum. Simple face mask is around 60%. Partial rebreathing is 70%. NRBM is 90%. Okay, maximum oxygen that you can give. High flow, there are two of them. High flow nasal cannula, it can give 100% oxygen, but it needs a separate flow meter. That flow meter can work at 60 liters per minute. That is why it is called a high flow. It works at 60 liters per minute. What happens is, the low flow devices, these are working between 1 to 15 liters. These are working between 1 to 15, up to 15 liters. Okay, up to 15 liters per minute. So this 60 is more than that. That is high flow nasal cannula. And because of the Bernoulli's law, because of that reason, Venturi mask, which causes air entrainment, it also leads to a very high flow of oxygen. So this Venturi mask is also used as a high flow device, but it provides only 60% maximum. So these are the maximum FiO2 provided by any device, and here is again the maximum FiO2. By Venturi mask you can give only 60%, by high flow nasal cannula 100%. Okay, but otherwise out of all the devices, NRBM gives 90%. Yes, Ambu bag, if you attach with oxygen, Ambu bag with oxygen with reservoir can also give 100%, around 100%, 90 to 100%. But Ambu bag, you will have to give IPPV. It is not free flow. Compared to that, all these others that you see, these are free flow. You can just give a tubing, you can just keep a mask, and here patient, you're not giving IPPV to the patient. Clear? So this is your oxygen delivery devices. Here, the low flow and high flow, you're not giving IPPV, but Ambu, you will have to give IPPV, and that was the answer. Okay, this question also done. Next one. Okay, a person presented to the casualty and is found to be hypotensive, dyspneic, and with altered sensorium, with a narrow complex QRS tachycardia. Ulta ho gaya, sorry, narrow QRS complex tachycardia. It should come here. Okay, narrow complex QRS, same thing. Narrow QRS complex, same thing ultimately, tachycardia. Which of the following is the next best step in the management? Yes, anyone? What's the answer? IV amiodarone bolus with infusion, IV adenosine stat, synchronized cardioversion, or defibrillation? Dr. Synergism, give one answer. Yes. Okay, so when you discuss these tachycardias, that is my point of view, how you tackle them, the way that we see. So always remember, these tachycardias, they can be divided into two types. One is narrow QRS complex, other is wide QRS. Okay, when you get a patient like this, each of them will have two parts. If the patient is stable, if the patient is unstable. I'm giving absolute in short from what I know medicine. Of course, medicine guys are better than me in terms of trying to teach you all this, but it is also included as a part of anesthesia. So I'm trying to discuss the best from my knowledge. So narrow and wide QRS both have stable and unstable. Remember, whenever a patient becomes unstable, how I remembered, whenever a patient is unstable, you are supposed to give a shock. Okay, whenever there is unstable, you give a shock. So if it's a narrow QRS unstable, you have to give a shock. But narrow means QRS complex is seen. You can see that. So you can synchronize here. So in a narrow tachycardia, QRS, synchronized cardioversion is one of the things that becomes important for an unstable patient. The way that you must have seen in ventricular tachycardia and ventricular fibrillation, if the patient is unstable as in patient with no pulse, patient with no breath, right, and on the ECG, ECG or the rhythm, defibrillator, you get the rhythm ventricular tachycardia or ventricular fibrillation. Remember what's the point? You need to defibrillate the patient. Defibrillation, right? That's what we study. So whenever it is unstable, you have to think of trying to give a shock, right? And that too pulseless. So they call it pulseless ventricular tachycardia, pulseless ventricular fibrillation. This is where you give a shock normally, yeah? The way to remember. In a stable patient, here you can do all those things, vagal maneuvers, right? Adenosine, because you have to limit the rate. You can give beta blockers, you can give calcium channel blockers, right? Stable patients, again adenosine, but adenosine is given it's a very short duration of action, right? You have to give fast immediately. You must have studied everywhere adenosine is given very fast. It works for a very short duration. And you can use amiodarone and infusion. Alright, clear? So now if you look at it, now you look at the answer. Amiodarone with a bolus, what have you got? We have got a patient who is hypotensive, BP is less, the patient is dyspneic, altered sensorium. You are dealing with an unstable patient, narrow QRS complex tachycardia. Ideally, you will not defibrillate. Your answer becomes synchronized cardioversion. Clear? Are bhai log clear? Okay. This is absolutely in short, and I think mine will not be so much be correct, but that is how I remembered. Okay, the medicine guys will treat you. Dr. Santosh and all will treat you much better than me. All these points they will teach much better. Okay, but that's how I remembered this point. Okay. Oh, this is a typing error. A 5-year-old is on 3 liter per minute oxygen via nasal cannula. What is the, this was the last question I had typed today. Sorry. So that's why that means the questions are more, huh? We have some more questions, but this is the one which I was typing. Some of them I typed yesterday. This was a typing error. So please, Dr. Synergism says, why not B? Wait, let me go back. Adenosine stat. Unstable hai na? Unstable hai. You are going to use adenosine in a stable patient. You are going to use adenosine in a stable patient, right? When the patient is unstable, means the BP is not getting maintained, you call it an unstable patient. Remember, for an unstable patient, shock. हाँ, इसमें adenosine भी दे सकते हैं, मैं मना नहीं कर रहा हूँ. Adenosine भी है, लेकिन unstable में एकदम first नहीं आता. That's what I'm trying to say. According to me, the answer should be synchronized cardioversion. But adenosine is also not wrong. I'm not denying. Okay. But according to me, the answer should be synchronized cardioversion because the patient is unstable. Okay. So Dr. Stardust says B. Okay, there's a doubt, but that's what I said. Dr. Santosh will clear it much better than me. They will also be coming up with this. They will be included there in medicine also. So according to me, the correct answer is synchronized cardioversion, unstable. Okay, my reason for it is unstable. When the patient is unstable, you're supposed to give a shock, and that is synchronized cardioversion. When the patient is stable, you can use any drug you want. Okay, that's my point of view. As I said, remember, I am sharing my knowledge with you. I am according to the best of my knowledge. So, and I said even before taking this question that Dr. Santosh will discuss it much better, but do pay attention to this part because this is where the confusion takes place, and this is how I remembered for myself how to remember. Okay, if it helps you, well and good, but yes, you have to confirm this from the medicine part. Okay guys, let's go to the next one. 5-year-old is on 3 liter per oxygen via nasal cannula, which we just discussed. What is the appropriate FiO2 level? So for this answer, remember, nasal cannula maximum FiO2 I just discussed with you was 44%. Maximum is 45%, 44 to 45. It works between 1 to 6 liters per minute, right? And it offers anywhere between 24 to 45%. Now there's a formula for this. The formula is 21 plus 4 multiplied by the flow rate. Okay, 21 plus 4 multiplied by the flow rate. So 21 plus, some books had mentioned 20 also, but nowadays they counted at 21. 21 is the room atmosphere, that's why. Okay, and flow rate, here they given 3, right? So 21 plus 12, right? How much does it become? 33. So now, two options can be there. 33 according to me is closer to 35. So I will mark the answer 35. That is what most of the students had said, because I had covered this question 2 years back also. You will find the same thing on the YouTube. And there also I've said the same thing. No, there I think we were discussing, I think this option was not given. You can find it out. But I had said ki if it is coming, if the answer comes to around 32, if the answer comes to 32, you will be keeping the answer as 30. But if you get 33, I will mark the answer as 35. Okay, so this is what is there. So according to me, since the answer that we are getting, we are deriving it as 33, therefore I will mark it as 35. Dr. Kumar Abhishek says 30%. हाँ, Dr. Kumar Abhishek, वही तो मैं बोल रहा हूँ. If we use the formula now 21, you derive at 33 and 33 will be marked as 35. In the old times, the formula was 20 plus 4 into 3, right? So this becomes 20 plus 12. Then the answer was 32. And in that case, it can be called 30%. So you see the discrepancy which is there. The same thing happens in every exam also. Alright. So Dr. Kumar Abhishek, you are also not wrong. But the point is, it depends what formula you are using to calculate it. If you are using the formula 21, according to me, if 33 comes and they are given 35, because this is closer, I will mark the answer 35%. And that's why these questions are those question mark questions, you know, actually have been asked correctly or something is wrong. If they are given two other options, 45 and 60, then I'll mark it 30. Right? If they don't give the option 30, they keep it 25, 28, 35 and 45. The answer becomes 45. The problem is when they give you questions which are not absolutely correct and they are in between, and you can expect questions like this coming in the exam. That's my whole point. Okay. For me, it was very simple to change this and just write it 38% and make the answer 30, and my question would have been done. But what's the point of then having a discussion? The discussion is to tell you to open your mind. Yes, I may also be wrong. The question may be wrong. But when you mark it in the exam, be sure that you know such questions come in the exam. Okay. You have to find the closest answer, even if you're not getting the correct answer. Okay. You have to find the closest way. All of us always say that, right? So hopefully pay attention to these points also. I'm not saying 30 is wrong. It depends what we are using it to calculate. And most of the times I don't expect they must have given 30, 35 both. I have included that deliberately. Okay. But normally they would not give it so that students don't get confused. But you never know them. You never know them. Huh? They might. Because you're trying to separate the students, right? It's an exam where you have to see that who secures a better mark. So they can give you any question. The next one. Which of the following corresponds to a ASA grade 3? A moribund patient, a patient having systemic illness which is under control or without any functional limitation, a patient having systemic illness which is not under control or with functional limitation, a patient having systemic illness which is constant threat to life. Okay, so this is ASA grading which is done pre-operatively as a part of pre-anesthetic checkup. This is done pre-operatively. This tells us about the physical status of the patient. It tells you about the medical status of the patient or the medical illness of the patient. How do you place a patient? A moribund patient not expected to survive is ASA grade 5 with or without surgery. Okay. A patient having systemic illness under control, this is called mild. In other words, that mild is missing. Mild illness which is under control, hence the illness is mild. This is ASA grade 2. Then you get a illness which is severe. This is called severe illness because it is not under control. Okay, this is ASA grade 3. That is my answer. A patient having systemic illness means this is severe. But now it is also a threat to life. This is ASA grade 4. Remember, ASA grade 1 is any normal patient. Clear everyone? And always remember, it's ASA grade 1 and ASA grade 2 which go for daycare surgery. Right? Because these are normally controlled patients. So that's what is mentioned. A normal patient is also under control. ASA 2 patients also under control. So these patients can go for daycare surgery. Clear? So that's the answer here. Option C. I think all of you mentioned it correctly. Dr. Kumar Abhishek, okay, Dr. Ritika and Dr. Synergism. Okay, again. Next. Alright. These questions again become very important. Questions based on this has been asked in NEET PG also this time around. Alright. So this point where they discuss an ABG, sort of an ABG, and they ask you what is the treatment. And these are those confusing questions that come in the exam. just like CPR types. Many times in CPR also such questions come. What should be the next course of action in managing a patient with pneumonia on ventilator? The patient weighs 50 kg. The patient on ventilator, by the way, respiratory rate of 14 breaths per minute, which is normal. Bicarb level of 18, slightly less, but we consider it as normal. थोड़ा सा कम है, right? pH of 7.33, which means acidosis is there. PaCO2 of 48. Okay. PaO2 level of 110. A PEEP of 12. A tidal volume of 420. And SpO2 of 100 with FiO2 of 90. Even before I go forward, the answer is given in the question immediately without even looking at anything. When you study physiology, the first thing that we study in physiology, when you study the respiratory system, you study, no doubt, if a patient is hypoxic, give oxygen. But if you give too much oxygen, this is itself toxic. Remember this? If a patient is hypoxic, give oxygen. And if you give too much oxygen for long duration of time, this itself becomes toxic to the patient, right? What has been given? You are giving the patient FiO2 of 90%. Remember, room air is 21%. The maximum we can ever reach in life is 100%. And the patient is already on 90%. Already on 90. Which means the patient is already on 90. And remember, 90% is going to be toxic to the patient, and SpO2 is 100. Do you remember when we study SpO2, a normal level of SpO2 should be more than 95%. In a patient like this, 94 to 98 is also considered normal. So why should I keep it 100% so that it can be toxic to the patient? I will need to reduce that. So this forms simple even without reading anything. But without that, but still, let's see the ABGs. First of all, they've given here the other parameters normal. 14 breaths per minute on the ventilator. Yes, it is considered normal. Bicarb of 18 is slightly less. I agree. So bicarb is slightly less. Okay. pH is also less. Do you realize this? The pH is 7.33 and bicarb is 18. PCO2 is 48. The normal value is 40 to 45. This is around normal. This is 7.35 to 7.45, around normal. This is considered 20 to 24, slightly less. So you find the ABG parameters are not deranged, right? Everything. Tidal volume is 420. So if you, the PEEP is mentioned 12, right? A PEEP is mentioned 12. A normal, if you will see, when you say a patient on ventilator, normally when you put a patient on ventilator, this time's NEET PG question, they are now say the lung protective strategy. Remember this question? If anyone has seen the paper this time around, NEET PG, lung protective strategy. What is the lung protective strategy? It is basically low tidal volume plus high PEEP. This was the question asked, if you remember. This time, lung protective strategy, NEET PG. What is the meaning of that? A normal tidal volume which you study in physiology is mentioned as 8 to 10 ml per kg. But for a patient on ventilator, this may be detrimental, especially on ARDS. It will be damaging to the lungs. So you will be giving a low tidal volume of 4 to 6 ml per kg, but you will compensate that by adding PEEP, positive and expiratory pressure. We can keep it between 12 to 20. Right? Here they mentioned the weight of the patient as 50 kg. Right? 50. So even if you take, okay, around 5, 6 are, alright, 50 kg patient, 300, right? So this is around 300 and the PEEP mentioned as being 12. So it is 300. Now, they are saying the other options, if you see, increase PEEP. Increasing PEEP is going to increase oxygenation. Do you want that? No. Correct? If you decrease respiratory rate, you are going to increase carbon dioxide. Do you want that? Which is already near normal? No. If you decrease FiO2, you are going to decrease the oxygen, which is good for the patient. If you increase tidal volume, you are going to decrease the carbon dioxide. Why? Because ventilation increases. So do you want to decrease the carbon dioxide of the patient so much? Normally everything is well maintained. What is the most harmful thing in the scenario? All of you have correctly given the answer, decrease the FiO2. My point was to discuss the other options also. Okay, so therefore if the question was that if it has been asked about any other thing, then in that case other parameters, then things would have been fine. But the options that they've given you are regarding FiO2, PEEP, RR and tidal volume. So no other thing is going to make a difference to the ABG so much, which is apart from decreasing the FiO2. So here just decreasing the FiO2 helps us to prevent the toxicity of oxygen in the patient. So this is the best answer according to me. Other things are not needed. You don't want to increase oxygen by increasing PEEP. You don't want to increase or decrease carbon dioxide because it is not much. It is 35, it is 40 to 45. The answer has been given 48. So it is not so much that you need to decrease that. Decreasing oxygen is more important because that may be toxic for the patient. Thumbs up guys, clear? Okay. Another now easy question. Alright, don't have to use brains. Simple question now. Which of the following statements given below is incorrect regarding? Dr. Synergism. Thank you Dr. Synergism. Chalo, thank you. Hopefully this is beneficial to you in the exams. Okay, then you can remember me and text me also. I'll share my number and Telegram ID. I like when you guys text me. Okay, because someone says that I got this rank, I feel good about it. I feel as if I've scored. I've secured the rank. Chalo. Which of the following statements given below is incorrect regarding CPR in adults? We just discussed. You should give me the answer now. Depth of chest compression 5 to 6, adequate chest recoil, ventilation and chest compression rate 100 to 120. Correct. Ventilation. So normally what is the problem here? The problem here is C. Ventilation 22 to 25 breaths per minute. No. Normal is 10 to 12 per minute. And on ventilator also you will see, we normally say a breath, how much you have given here? 14. See, so whether it is a ventilator also, you are going to give 12 to 20 breaths only to a patient, not more than that. During CPR, a breath of 10 to 12 is more than sufficient for the patient. A rate of 20 to 25 is wrong. Depth of chest compression 5 to 6, yes, it is correct. Adequate chest recoil, yes, it's important. Chest compression 100 to 120, correct. But ventilation is between 10 to 12. Clear? So answer is C. Simple question. Next. Okay. A 60-year-old male patient is undergoing laparoscopic cholecystectomy. During the surgery, a sudden decrease in EtCO2 to 8. Right? A patient's SpO2 was 90. Peak airway pressure was 18. Blood pressure dropped to 80 by 50. Which of the following is the most probable diagnosis? Okay. Pneumothorax, endobronchial intubation, CO2 embolism or bronchospasm. Okay. Patient is undergoing surgery. Correct. Laparoscopy. Remember, what we are discussing is a laparoscopy case. We are discussing laparoscopy. There is a sudden decrease in the EtCO2. You need to understand when there is a sudden drop in EtCO2. A sudden drop in EtCO2. This is the answer. Okay. Patient's SpO2 was 90. Peak airway pressure was 18. This is considered normal. Okay. And blood pressure also decreased. So I have seen three things in the patient. You find that there was a decrease in blood pressure, there is decrease in SpO2 and there is decrease in EtCO2. Three things. That too in a patient undergoing laparoscopy. You have your diagnosis right in front of you. When laparoscopy is going on, can pneumothorax take place? Yes, it can take place. But in that case, peak pressure will increase. It will not remain the same. Right? Endobronchial means your tube has gone to one side. What will happen? Yes, can there be a decrease in saturation? Yes. Fall in BP? Yes. EtCO2? We don't know. But will the peak pressure decrease? No. It will increase or it will remain normal. It is gone in one bronchus, your peak pressure will increase. Bronchospasm. Do you realize pneumothorax, endobronchial intubation, bronchospasm are all related to the respiratory system? They are all related to the respiratory system. Something is going wrong in the respiratory system. This is happening in the patient directly, all over, systemic. This is happening not one system, all over. So ultimately, the three things, all of you have given the answer correctly, but I am telling you how to see that in the exam. So remember, the other three are from the RS. This is from the CVS also. And this is where you get the answer. that you are going to see CO2 embolism. Talking about the graph, in a capnography embolism, you will get a sudden drop. It was going normal and you get a sudden drop in EtCO2. In a bronchospasm, you get a graph like this. All of you already know it. It is regular. It is not a sudden drop. Pneumothorax will again lead to a graph like this. Alright. Endobronchial intubation. Yes, it is obstructed. Peak pressures might be coming high, but the capnography graph will look like this. There is only one graph where you will find directly coming down to 0 or a sudden drop in EtCO2, because the normal EtCO2 value is 40. It has come down to 8, and the answer there is carbon dioxide embolism. Clear, everyone? So the correct answer here is CO2 embolism, which most of you have given the correct answer. All of you, in fact, all of you who gave the answers were correct. Next, 15-year-old boy reported to emergency with a breathing difficulty, and the following image is seen on capnograph. What does it indicate? Pericarditis, bronchial asthma, tamponade, or viral myositis? Yes, correct. I think answer aa gaya answer. Correct. Rightly said. Rightly said. What's the answer then? You can already see this is a capnography. Capnography is a graph of carbon dioxide. Okay, and the capnography is coming regularly, but is it coming normal? No. The normal should have been like this. The normal should have been like this. Normal should have been like this. So what has happened? It is not coming normally. It has become obstructed. What is the obstruction you can see here? Bronchial asthma. B. All of you have mentioned it correctly. Okay. Remember, EtCO2 is a graph of carbon dioxide. Whenever you get carbon dioxide during expiration, you get a graph like this. What does it signify? The graph going up means expiration and the graph going down is inspiration. So if you will take the points in the capnography, A, B, C, D and E. So remember, A to B, this is the baseline and the dead space. Okay, this A to B is basically the dead space gas or the baseline. The C to D is a mixture of alveolar and dead space gas. The C to D, this is also called as alveolar plateau, because this is your alveolar gas coming out. In fact, point D, this is maximum alveolar carbon dioxide. Remember, in fact, this is what is called EtCO2. This point D is what is called EtCO2, end-tidal carbon dioxide. It's the maximum alveolar CO2. So C to D represents the alveolar plateau. It's only the alveolar gas. So A to B is dead space baseline. B to C is a mixture of alveolar and dead space gas. C to D is just the alveolar carbon dioxide, and D to E becomes inspiration. And whenever this comes continuously, you get a graph like this. Clear? So graph going up here is expiration and going down is inspiration. This is your capnography. Next question. Okay. For 42, I have got some more questions. How many questions are there? I will have at least 4 or 5 more questions. So I'll finish off in another 15 minutes. Is that okay, everyone? 15 minutes. About 6-7 questions are there now. Okay. About 15-20 minutes we'll finish now. Hopefully you understood till now. We'll take this question. A 42-year-old male tested positive for COVID-19 was isolated at home, presents to emergency room with difficulty in breathing. The patient is conscious. So let's look at them one by one. The patient is conscious, is responsive, right? Has increased respiratory rate. This is increased. Oxygen saturation has a reading of 86%. So SpO2 is 86. Remember previous question, SpO2 was 100. Here 86 means hypoxia. Remember, SpO2 should be more than 95%. It is not 95, it is 86. So what happened? You gave face mask to the patient with a reservoir bag, which means you have given the patient non-rebreathing mask, NRBM, right, at a flow rate of 10 liters per minute. NRBM, it works between 10 to 15 liters, providing a maximum of 90% FiO2, right? So you have given 10 liters, which is okay, it is giving 90%. Following 1 hour trial, SpO2 has become from 86 to 88. Is it normal? No, because my SpO2 of the patient should be more than 95% here. It is COVID-19, not COPD. Had it been a COPD patient, I would have still compromised. Why? A COPD patient does not need so much oxygen. Here, less oxygen is okay with me. So what I will do is, what is my next step? Can I increase the flow rate to 15? Yes. Because maximum is 15, I can increase it. But is it going to serve any purpose? Not much, because it works between 10 to 15. It's not going to make from 88 to 95. What can I do next then? Do I need to intubate the patient? Yes, I can do intubation. Will it increase? Yes, no doubt. High flow nasal cannula oxygen therapy. HFNC. Remember, oxygen delivery devices are of two types, low flow and high flow. The high flow can give 100% oxygen at 60 liters per minute flow. That's why it's called high flow. Last is no specific intervention. At 88%, patient is tachypnea, increased respiratory rate. Will you not intervene? I will intervene. So what will I do? Out of the three options which have been given to me, I will choose high flow nasal cannula. That is exactly what is done. The lowest part is the nasal prongs. Then comes the simple face mask. After that comes the partial rebreathing mask. Then we come to the non-rebreathing mask. After that is the high flow nasal cannula. If it doesn't improve, we go to non-invasive ventilation, which is CPAP or BiPAP. If the patient doesn't improve, because CPAP and BiPAP are given in a spontaneously breathing patient who is having a face mask, a tight face mask, right? And after non-invasive, the next step is to go to invasive ventilation, which you put the patient on ventilator, and now it is given either by endotracheal tube or tracheostomy. This is what is the grading of the devices which are done. So nasal prongs and nasal cannula, simple face mask, partial rebreathing, non-rebreathing, high flow nasal cannula, then you go to non-invasive CPAP and BiPAP, and finally invasive ventilation. Clear? Dr. Shashank, give a thumbs up. Okay, clear. Next question, simple one. Which is the most frequent reason for hospital admission following a daycare surgery? Is it respiratory distress, post-surgical pain, post-op nausea, vomiting, or bleeding? Your patient was supposed to go home. It's a daycare surgery. See, daycare is an important question. They are asking it again day in and out. They ask you these questions. Okay, surgery has been done, but you don't send the patient home. Of course, respiratory distress you will not send. Pain, of course, pain you can send. Yeah, you can give 4 or 5 medicines. Of course, that's a reason. Remember, these two are the most common complications which you see. But the reason for hospital administration, correctly said by Dr. Ritika, is C. Alright? And bleeding, of course. But bleeding का problem क्या होता है? When the surgery goes home, so patient goes home after surgery and he then reports bleeding. The readmission is very commonly with bleeding. Okay? With bleeding, readmission after going home means patient goes home and he starts to bleed. You think a patient has undergone MTP or a patient has undergone suction evacuation. Daycare procedure, a patient has undergone cataract. They go home and they say, I'm bleeding. Will you let them be at home? No, you will call them. Readmission after going home. So bleeding is one of the most important reasons for that. But if a patient is saying, I'm vomiting, I'm not feeling well, I'm vomiting after MTP, after suction evacuation, after ophthal surgery, you think ophthal has been done, ophthal surgery, and patient says, I'm vomiting, will you send the patient home? No. That is the reason for hospital admission after a daycare procedure. Post-op nausea, vomiting is one of the most common causes for that. Dr. Bhakti has asked me a question regarding the previous one, and that is, if SpO2 goes from 84 to 80, then would BiPAP be the answer? Okay. Let me put it this way, Dr. Bhakti. If instead of D, if someone cancels this D and gives me an answer BiPAP, so now you have got 4 options: increase flow rate to 15, endotracheal intubation, high flow nasal cannula, and BiPAP. What will you do? Now, remember, BiPAP definitely is a better answer than high flow nasal cannula, but remember, always they say a non-invasive thing is better than an invasive. So tracheostomy and endotracheal tube is out. Out of these two, remember, before you go for CPAP and BiPAP, there's no harm giving a trial of high flow nasal cannula and then going for BiPAP, because that comes in the next order. Okay, but if high flow nasal cannula is not given and then they've given BiPAP, definitely that's the answer. Okay, then that is the answer definitely. Now, if the SpO2 is falling down, the question is that instead of 86 to 88, if from 86 it goes to 80%. Remember, at 80%, the patient's respiratory rate will increase. Now, if you have got both the options, high flow nasal cannula and BiPAP, this is the question of Dr. Bhakti. What will you do? high flow nasal cannula is not going to, you can give some amount of PEEP here also, huh? Here also some amount of PEEP can go in, but it is only going from a nasal cannula. It is not going to open up the airways for greater gas exchange. Wait, कुछ तो हिल गया यार screen पे. Can you see it clearly? Something is wrong. 1 second, guys. Something wrong with my screen. No, here it is fine. Here it is fine. Here it is fine. Okay. Now it's okay. I know, Dr. Bhakti. Even I could see myself. Okay, getting blurred. Alright, hopefully things are clear. So, right, so Dr. Bhakti, now the point is, no doubt you can give some amount of PEEP. So, if both these options are correct, I have to choose one and the saturation is falling down, then I will not choose high flow nasal cannula. In that case, I will go for BiPAP because saturation also is increasing, and here we are not giving so much PEEP as much as the BiPAP. So, according to me, if the question is what Dr. Bhakti asked me and these two options are only given, I will go for BiPAP. But normally they will not give you high flow nasal cannula and BiPAP together. They will specify the question. Otherwise, it is very difficult for that. Clear, Dr. Bhakti? Just that high flow nasal cannula is a different kind of machine that you're supposed to use. So this question is also done. Next also done. Which of the following can be used for induction of anesthesia, maintenance, and can be safely used in endotracheal intubation? Yes, which one? You're welcome, Dr. Bhakti. Thank you. Okay, which of the following can be used for induction of anesthesia, maintenance, and can be safely used in endotracheal intubation? Simple. Remember one drug I have said mentioned before also, which can be used everywhere. What drug is that? Wait, I think I will need to re-log in again. Just give me 1 second. Just give me 1 second because I will stop and again I will do it. Just give me 1 second, guys. Okay. Now it's fine. Yes. You never know that sometimes all these, while relaying, anything can happen. What was the answer, guys? Answer though. Anyone? Dr. Kumar Abhishek says C. Nice. We discussed this answer before. It is sevoflurane, right? Safely for induction. What's the reason for intubation, guys? In sevoflurane, it has one property. It causes maximum skeletal muscle relaxation. Do you remember I discussed that halothane causes uterine muscle relaxation? Similarly, with sevoflurane, you find maximum skeletal muscle relaxation, which means it can cause paralysis. It helps the paralysis. And that is why when you want to intubate also someone, sevoflurane, that one drug becomes very important. It's also called as a single agent or a sole agent for intubation as well as induction. Induction as well as intubation. Single or sole agent which can be used. Okay. Doctor, nahi D answer nahi tha. Koi D answer bhi tha. D is not the answer. C is the answer. Sevoflurane. Okay. It's not isoflurane. Remember, isoflurane khali ek hi jagah. Ideally speaking, isoflurane is the best drug for CVS. No doubt, you can use it in CNS also. I'm not denying. Right. It can be used. It decreases intracranial pressure. I'm not denying. And apart from that, liver transplant. Okay, apart from that, we don't use isoflurane so much. It's a good drug though. Next, during resuscitation, a patient received 20% intralipid, right? What could have been the most probable diagnosis? Local anesthesia toxicity, asphyxia due to drowning, electrocution, or pulseless electrical activity? Yes. Simple question. Yes, it is local anesthesia systemic toxicity. Remember, local anesthesia systemic toxicity is called last when you have injected the drug. Two types. If your drug has gone in the blood vessel, the local anesthesia is injected in the blood vessel itself, so maximum systemic absorption takes place, or you give very, very high doses of local anesthesia, right? And in that case, normally you will find the CVS complications taking place before the CNS complications. The CNS complications taking place before the CVS complications. The patient gets convulsions before the arrhythmias. But there's only one drug which is the most cardiotoxic. Remember that. where you get convulsions and arrhythmias at the same time, right? And that is the most cardiotoxic drug. Which one is that? Bupivacaine. And normally bupivacaine is the drug which produces this arrhythmias and all, okay? Bupivacaine. And this intralipid was normally made for bupivacaine toxicity, right? Bupivacaine toxicity. So therefore bupivacaine is the most cardiotoxic, and this is where you will use it. So correct answer is local anesthesia systemic toxicity. So treatment of that is using 20% intralipid. You also give small doses of adrenaline. Small doses of ADR are also given, very, very small doses, okay, apart from that, intralipid. Next question. Regarding the initial setting for a patient with blunt chest trauma who has been initiated on mechanical ventilation. Remember this question on mechanical ventilation, road traffic accident, pneumothorax, always some questions is going to be asked based on this, okay? Something or the other is definitely asked from here. These points, I'm just telling you the point. It's not related to this question, but I'm just telling you regarding the initial setting for a patient with blunt chest trauma who's been initiated on mechanical ventilation, which of the following statements is incorrect? Incorrect. So respiratory rate 12 breaths per minute, PEEP of 5, FiO2 of 100, tidal volume. So therefore you are just starting the mechanical ventilation. Initiation means you are starting. I'm just starting the ventilation of a patient. Is respiratory rate of 12 breaths per minute good to start with? Remember I told you respiratory rate 10 to 20. Normally in CPR we give 10 to 12. Ventilator we keep 12 to 20. So this is correct. Yes. PEEP of 5 to start with? Yes. Maximum with ARDS you can go up to 20. But yes, to start with 5 is okay. FiO2 100? Yes. To start with is 100 and then slowly decrease as early as possible. Slowly decrease to 60. This is the basic point of ventilator. Slowly decrease to 60 as early as possible. Not slowly, but titrate it to 60. Titrate and decrease to 60% as early as possible. Let us look at the next question for which I gave you the answer. Tidal volume 12 mg per kg of actual body weight. 12 mg per kg. I just told you physiology they have mentioned in physio textbook. Normal tidal volume is 10 to 12 ml per kg. Sorry, 8 to 10 ml per kg. Now this patient has got chest trauma. So in a chest trauma patient, tidal volume of 8 to 10 is normal. I mean, you're saying it's a normal. I had told you for ARDS and nowadays for for ventilation, the lung protective strategy is a low tidal volume. Remember 4 to 6 ml per kg plus high PEEP. This is what is called as a lung protective strategy. The same question, NEET PG this time around. The lung protective strategy. So nowadays you want to reduce the tidal volume to 4 to 6, but on the other hand the question is saying you give 12 ml per kg. Means don't you think someone who's got a chest trauma, by giving 12 ml per kg, thak, lung fat jayega. So therefore the correct answer is D. You will not be using 12 ml per kg. Okay, the initial part you are not going to use because there is chest trauma present in the patient, blunt chest trauma. You are not going to use 12 ml per kg. It's a huge tidal volume for the patient. You will give it less. Okay, Dr. Synergism, is it correct? The answer is D. I think Dr. Kumar Abhishek and Dr. Ritika gave the answer D. Right? If option was ventricular arrhythmia, where in ventricular arrhythmia, Dr. Synergism? कहाँ पे? Clear guys, understood? ठीक है? So यहाँ पे the correct answer is tidal volume 12 is wrong. You will be giving 4 to 6 ml per kg, which is your lung protective strategy. फिर से refresh करूँ यार. बीच मैं खुद को ही नहीं, I can't see myself at times. Now I can see myself. Now I can see the messages also. Yes guys, all okay? Thumbs up. May I go forward then? Dr. Shashank says thumbs up. Chalo. Next, as I said, another 5-10 minutes more. I'm done, almost done. Which of the following methods cannot be used to determine cardiac output? Easy. Which of the following Dr. Bhakti also says gives a thumbs up. Thank you. Done. So let's finish off the next 3-4 questions fast. Which of the following methods cannot be used to determine cardiac output? Even if you don't know, you know the answer. Dr. Synergism says last question for last. Okay. Got it. Wait, I'll come to this question again. Dr. Synergism has a doubt. Let me go there. He was asking about this question. पहले मुझे question नहीं समझा. Okay. So he is saying during resuscitation patient got intralipid therapy with arrhythmias. You're saying. अरे फिर भी आंसर यही हुआ ना. अच्छा, you are saying like this. If the option is arrhythmia. नहीं, क्वेश्चन क्या पूछा था डॉक्टर सिनर्जिज्म? क्वेश्चन क्या था उसमें? योर क्वेश्चन आई डिडंट अंडरस्टैंड. यू सेड अरिथमिया, लेकिन इफ ऑप्शन वाज अरिथमिया. ओके, यू आर सेइंग इंस्टेड ऑफ बी इफ द प्रॉब्लम इज अरिथमिया. ओके, नो, रिमेंबर इंट्रालिपिड इज अ ओके आई अंडरस्टूड योर पॉइंट. ओके, अ गुड क्वेश्चन, राइट? द वे दैट डॉक्टर सिनर्जिज्म हैज आस्क्ड. अपना नाम ही लिख देते हैं ना, मैं डॉक्टर सिनर्जिज्म बोल रहा हूँ. नाम से पेरेंट्स हैव केप्ट सच लवली नेम्स. ही हैज मेंशन्ड arrhythmia. ठीक है. If one of the option is given arrhythmias, so during resuscitation a patient received 20% intralipid, what could have been the most probable diagnosis? Guys, अगर patient को arrhythmia हुआ है, this question is not about local anesthesia. They have not asked this. They are just saying you get a patient who has been given 20% intralipid. Intralipid. Remember, intralipid is used only in two places. Intralipid is used in total parenteral nutrition in the ICU, and the second reason to use intralipid is just for one thing, that is bupivacaine toxicity or local anesthesia systemic toxicity. Out of all the options, if it was given total parenteral nutrition, yes, that could have been fine, but it's not about TPN because the patient was under resuscitation. So TPN क्यों आएगा, right? The only answer left is local anesthesia systemic toxicity. Remember, intralipid is not a treatment of arrhythmias. Intralipid is a treatment of bupivacaine toxicity, the arrhythmias that it produces. It is not for normal arrhythmias. For arrhythmias, the treatment is going to be anti-arrhythmic agents, right? Depending on what kind of arrhythmia. Remember, I just discussed with you that narrow angle and wide angle arrhythmia, right? That is all that only, na? Sorry नहीं है, अरे correct है. I said it's a very good question. My point is you should not get confused with such simple questions, guys. इतने गंदे क्वेश्चन आते हैं ना कि ये सब क्वेश्चन यू शुड गेट द करेक्ट मार्क्स. माय पॉइंट इज दैट डॉक्टर सिनर्जिज्म वेरी गुड. इट्स अ क्लैरिटी फॉर समवन एल्स ऑल्सो. योर क्वेश्चंस हेल्प समवन एल्स अंडरस्टैंड. इट टेल्स यू हाउ यू आर थिंकिंग, हाउ फास्ट योर ब्रेन इज थिंकिंग. इट्स नथिंग रॉन्ग, ओके, बट जस्ट लुक एट हाउ यू सपोज टू गो फॉर द आंसर. अरिथमिया का क्वेश्चन आएगा तो यू आर गोइंग टू लुक एट एंटी एरिथमिक्स, राइट? बेस्ड ऑन एंटी एरिथमिक्स, क्लास 1A, क्लास 1B, यू हैव स्टडीड ऑल दैट, ओके? सो नो प्रॉब्लम ओवर देयर. ठीक है, बट दैट इज अ गुड डाउट विच यू हैड. इनफैक्ट आई फाइंड इट्स अ गुड डाउट. सॉरी नहीं बोलने का. कमिंग टू दिस क्वेश्चन नाउ, यहाँ पे कैप्नोग्राफी इज द आंसर, करेक्ट, बिकॉज कैप्नोग्राफी टॉक्स अबाउट कार्बन डाइऑक्साइड एंड नॉट कार्डियक आउटपुट. दैट इज द आंसर. इवन इफ यू डोंट नो एनीथिंग, एटलीस्ट यू नो कैप्नोग्राफी. माई पॉइंट इज दैट यू डोंट नो व्हाट इज थर्मल डाइल्यूशन, यू डोंट नो इसोफेजियल डॉपलर, यू डोंट नो एकोकार्डियोग्राफी. कुछ नहीं पता हम लोग को. वी हैव नॉट स्टडी एनीथिंग, बट आई हैव स्टडीड कैप्नोग्राफी. So capnography measures carbon dioxide, it does not measure cardiac output. So the answer is capnography. ठीक है? It cannot be used to determine cardiac output. Simple? Clear? Next, which of the following gases is delivered through blue pipeline in the operation theatre? Simple. After 2 hours, simple question. Okay? Alright, which of the following gases is delivered through the blue pipeline? Clear? Everyone knows the answer. ठीक है? Nitrous oxide. Remember, oxygen is always pipeline, white in color. Nitrous is always blue in color. Air is always black in color. Vacuum is always yellow in color. Correct. All of you have given the correct answer. All of you. Why will I ask this? Let's talk about cylinders then. What are the color of the cylinders? Oxygen is black body with white shoulder. Nitrous, as usual, blue. What is going to be air? Gray body with black and white shoulder. Then you have Entonox. So if someone says Entonox, combination of oxygen and nitrous, so it becomes blue with white or blue with blue and white, right? And the last is carbon dioxide, gray in color. Pin index, air 1.5, oxygen 2.5, nitrous 3.5, alright, Antonox, biggest name 7, carbon dioxide 1.6 and 2.6. Clear? So these are all your cylinder colors. Pin index, these are the, remember, pin index is what prevents the wrong attachment of cylinders. Alright, these were simple questions. At one time they were asked in the exam. Nowadays these questions they don't ask in the exam. Okay, at one point of time you'll find all this being asked again and again. Now they don't ask you. Alright, I think this is the last one or one more after that. नहीं, तीन और है. चलो फटाफट complete करते हैं. I know I want to leave you guys also. Simple questions, but while taking a morning stroll in the park, you come across an individual who's unconscious and lying on the ground. What would be the most appropriate course of action to take from the given choices? Check for the pulse, start CPR, call for help, defibrillate. Call for help, check pulse, do CPR and defibrillate. Observe, ignore and continue to walk. Simple question. Yes, answer is whenever you see someone lying, the first step is always scene safety. Correct, the answer is B. Correct. After scene safety, the next step is check for response. After checking for a response, patient is not responding, then you call for help. After calling for help, the next step is check for breath and pulse. You will check breath by looking at the chest rise. Pulse is checked by carotid or femoral. Pediatric patients brachial. If pulse and breath both are present, keep in the recovery position. If breath is absent, give breath. If pulse and breath both are absent, start CPR. Okay, chest compression, airway breathing. Continue that till the time, because remember it called someone for help. When these people come with a defibrillator, you assess the rhythm and then defibrillate if needed. Right? All you need to do is continue cycles of 50:2. So that is how the CPR is done. So here the point was call for help, check for the pulse. Okay? The third step is do CPR and defibrillate. That's the answer B. Which of the following is the most potent local anesthetic agent? Simple. These two are inhalationals. We don't even have to talk about it. At one point, such questions used to come in exam. Nowadays, don't expect such questions to come in exam. Okay? Alright? Correct. Here the answer is D. When you divide local anesthesia drugs, they are divided into three types. Remember, lignocaine is intermediate. It is bupivacaine, which is long acting and highly toxic. So there are three types of, based on drug properties, you divide local anesthetics into three types. One, which are short duration of action. These drugs are less toxic. Then you get intermediate duration of action. These are intermediate toxic as well as potency. So this is less potent drugs. These are intermediate potent drugs. The last group is long duration of action and highly toxic. The long duration, highly toxic, and these are highly potent drugs. Right? So here you have procaine and chloroprocaine. Here you have lignocaine, mepivacaine and prilocaine. Here you have dibucaine, longest acting, tetracaine. Here you have bupivacaine and ropivacaine. The correct answer is bupivacaine. Clear? D. Next, a neonate is brought to the pediatric ER in acute respiratory distress. On examination, abdomen is scaphoid. Which of the following should not be performed? Simple. They have spoken about a neonate. Neonate means just born. Acute respiratory distress. Patient is brought with a distress. Abdomen is scaphoid. I am suspecting congenital diaphragmatic hernia, where intubation, oxygen therapy are important. Nasogastric tube can be done. What you will not do? Contraindication is a bag mask ventilation. Clear? All of you already know this. Simple question, but you have to identify that it is CDH. Congenital diaphragmatic hernia is a contraindication for bag mask ventilation. Clear? Yes, everyone. The correct answer is B, bag mask ventilation. Alright, may I go forward? Okay, steps of intubation sequence. So we've done the bag mask ventilation. Okay, so remember, bag mask ventilation normally is contraindicated where? Let me discuss that point before I go to the last one. Okay, that should be the last question, I think. That is the last question beyond this. ठीक है, हाँ, hopefully ये last question. Then I can ask. Then if you have any doubt, you can ask me. This is the second last question. Okay. So I think most of the questions are included from 2021 onwards. I think so, right? Most of them from INICET exams. So which of the following should not be performed with CDH? I am going to discuss with you what are the places where bag mask ventilation is contraindicated. So any place which is considered as risk of aspiration is considered as a contraindication to bag mask ventilation. A risk of aspiration condition is something like a patient who is full stomach, someone who has eaten food before surgery, right? Full stomach patient. Full stomach patient, apart from that, can be someone who's pregnant, baby in the stomach, someone having obesity, tumor, ascites, intestinal obstruction, volvulus, hiatus hernia. Okay? Apart from that, anything which has got delayed gastric emptying, even that can be included, and congenital causes like congenital diaphragmatic hernia, tracheoesophageal fistula, pyloric stenosis, meconium aspiration syndrome. These are congenital emergencies which are considered as risk of aspiration. These are all contraindications to bag mask ventilation. Okay, in these patients, in fact, before surgery, if these patients come in for surgery, they are risk of aspiration before surgery also. How to intubate them? This is where in a full stomach patient, all of you must have heard that we use something called as cricoid pressure or Sellick's maneuver. Okay, this becomes important. This is applied by an assistant. An assistant gives a cricoid pressure so that he compresses upon the cricoid cartilage, which compresses below the esophagus. So if this is your trachea, the only complete ring in the trachea is the cricoid, right? This is the trachea. Next to the trachea is the esophagus. Okay, the only complete ring in the trachea is the cricoid. Rest all other rings are half rings. Correct? So if you press upon the cricoid cartilage, what happens is the cricoid compresses against the esophagus like this. Because this is complete ring, rest others are half rings in the trachea. So this is your cricoid pressure. It compresses the esophagus. By chance there is any regurgitation happening, it helps to stop that regurgitation from going up, and aspiration. Okay, so this is what is called cricoid pressure, which is supposed to be used if there is a full stomach patient coming for intubation. Okay, cricoid pressure or Sellick's maneuver. Okay, steps of intubation. What are the steps of intubation? Flexion of the lower cervical spine, extension of the atlanto-occipital joint, inflate cuff of endotracheal tube, introduction of laryngoscope from the right side of the mouth, and confirm the position of the tube. What are the steps? What are you going to do first? Yes. What is the answer? Is it A, B, C? Alright, A, B, D, C, B, A, C, D, or A, C, B, D? Clear? Anyone? Okay, this is the last question. If there are any doubts, I'll take the doubts and then we are done. Okay. Steps of intubation sequence. You are supposed to intubate someone. What is the first thing that you do? First thing, you keep a patient in the position. What is the position? Again, question was asked in the exam. Sniffing position. You keep the patient in the laryngoscopic position. What is the laryngoscopic position? Laryngoscopic position is what is called as the sniffing position or the McGill position. You keep a pillow below the occiput of the patient. That's the first thing which you do. So A is the first thing that I will do, right? After I make the sniffing position, right? Here the three axes come in one line. What happens here is you are supposed to do head extension and neck flexion. So what is happening here is extension of the head and flexion of the neck takes place. Again, this was an MCQ question. Clear? The second part is after that you will, once you make the position, sniffing position, the second is we are intubating someone. You are supposed to introduce the laryngoscope from the right side of the mouth, push the tongue to the left, locate the epiglottis and lift it upward to visualize the vocal cord. Once you visualize the vocal cord, you intubate the patient, which has not been mentioned here. After intubation, the third step is inflate the cuff. After inflation of the cuff, the fourth step is confirm the position. Okay, so the first step was make the position. They missed one point in between, which has to be intubate the patient. So you make the position. After the position, the next introduce the laryngoscope. So position, introduction of the laryngoscope. After that, you intubate the patient. After intubation of the patient, you inflate the cuff. After inflation of the cuff, you confirm the position. These are the 5 steps that you will do. So here position A. So this A we have to see. So question option B is option C is out. The next is you are going to see A, C. Where is C, the second one? So answer is D. A, C, B and D. The first thing was you are giving the position of the patient. Then it came introduction of the laryngoscope. Then came inflate the cuff. And the last was confirm the position. Clear everyone? So the answer is D, steps of intubation. Right? So with this, I finished a lot of questions, hopefully, which should be of some help to you for your INICET exam. Any questions and doubts you can ask me, right? Otherwise, I'll share my number with you. Any questions and doubts you can ask me directly. You can WhatsApp or do a Telegram. Okay, so I'll just share. You can WhatsApp me directly, or you can at Instagram, you can Dr. Vinish, VINISH. Okay everyone. So any questions and doubts, please let me know. I'll try to solve them. Anything that you have in your mind, otherwise we'll end the session. And thank you for sitting with me for all through this 2.5 hours. Dr. Synergy, सबके answers, questions तो आ गए. In between, I was not getting the, the answers which you gave. Yes, anyone? Any questions or doubts? Thank you, Dr. Synergy. हमारे नाम तो बता दो. नाम होना चाहिए. Dr. Abhishek says, thank you. Thank you, Dr. Abhishek. Thank you, Doctor. Thank you. Any other questions or doubts, guys? Anything that you want to ask me? Okay, otherwise I'll end the session, because for 2.5 hours, all of you were like, I don't know whether you were glued or not, but yes, I could see all of you responding so well, and thank you so much. Thank you, Dr. Bhakti. Next session says Dr. Synergism when? नहीं, anesthesia का तो मुझे पता नहीं, we'll schedule it here. But from anesthesia I've done 2. I've done a TND also. I have done a previous, my INICET I finished off last month. For INICET, I was having a test and discussions. I think that's on the app. If you have the app, then you can go and see on the app also. I finished that one session where I took 51 questions. Or is there on YouTube? I forgot. Yeah, we keep on taking sessions. I don't even remember. Okay. Any questions or doubts? Otherwise, guys, anything from anesthesia that you want to ask me? Dr. Bhakti says, sir, for FMGE, FMG मेरा आने वाला है schedule. FMG on the app, I'll be there in December, I think, or November. We'll keep on posted, guys. I mean, you guys join us at the PW MedEd channel, and then we'll keep on letting you know the things. Okay, just join the channel. You'll keep on getting the updates. Because normally when we don't know, with hospital duties and teaching, so both of them have to be mixed together. Plus at a time when it is relevant to you. Because this time was important for the INICET. FMG is slightly late, so we are going to do that in November or December. Okay. So just join us on the group, on the Telegram groups that are there, right? On the YouTube group, you'll keep on getting the updates. Whichever thing you think, it's not just that you have to go through everything, but anytime you think the subject is not good, any subject that you want to prepare well, and plus we have interaction with all the teachers or the faculty possible, all the group we are available. So many times what happens, you want to ask a question, you are confused, you can post it on the group and we try to solve them to the best of our knowledge. Okay? Thank you guys, thank you so much. I'll stop the session then. Okay? And all the best guys, do well. Thank you for joining. It was a lovely session. The way all of you contributed to it, they gave answers. I also felt good. Initially I thought I'll take only for 1.5 hours. Lekin fir, all of you were keen, so I tried to go into all the topics and take, some revision part of each of them. Okay, so all the best and do well. When you guys clear, get a good rank, please let me know. We feel good about it. Okay, bye. Good night and all the best. Do well. Solve GTs.